I would like to turn it over to our chair, Sue Birch, to welcome all of you today. Sue?
Yeah, so thank you all so much for joining. I think there's an echo, hopefully. It stopped. Okay.
I think it's better now.
Jamie, I'm going to test that one more time.
Go for it.
I think we got it. Okay.
Yep.
Thanks everybody for joining in. It's fabulous that we have such robust participation from the public. I do want to thank you all for taking the time to read the information. HMA is going to walk us through some fabulous slides. You know, this is a journey that we're on. It's a process. And so we have to keep being patient, but keep making strides forward. And I just want to thank you for being in that process and going through this hard work together. Given that we've got everything else going on in the state, it is really, truly remarkable that we remain dedicated and moving forward. And we commit to you that we will do that. And we are hopeful that, you know, we will get to that report phase. But really, more than anything, thank you for your patience and your understanding and for your just constant attention on working with us as we come up with the best scenarios and information possible for our state. So Jamie, I'll turn it back to you.
Thank
and
you,
we'll get going on our day.
That's great. Thank you. Liz, can you advance the screen? I'm going to walk folks through our agenda. So we have two big objectives today. The first, well, we're actually three big objectives. We're going to hear public comment on universal healthcare first. We've actually, those of you who've taken a look at the agenda probably noticed we moved it up in our schedule today. And we did that for two reasons. One is so that we can create an opportunity for our work group members to hear public comment and maybe think about that comment as they're deliberating rather than having it happen after the fact. And the other is hopefully to make this more convenient for our members of the public and minimize, can you pop back up one to the objectives? Yeah, and minimize the number of folks who signed up to comment but weren't able to stay for the whole meeting. Our other objectives today are moment you've all been waiting for. We're going to review and understand the outcomes of the actuarial analyses so the data you can use the data in your decision-making work group members. And then also we wanted to spend some time really diving into and understanding and deliberating on the work that remains to design a system of universal health care, including policies and legal administrative hurdles and financing. This will inform both your deliberations about which models to recommend, models to recommend to the legislature, and also help you articulate proposed next steps in that report. And then finally, as ever, we're going to confirm action items and next steps. Liz, can you advance the screen? Thank you. All right, so after we review the agenda, we're going to dive right into our public comment period. That's going to be 20 minutes. And then at 1:40, we're going to start our first set of breakout groups. We're going to review the outcomes of the actuarial analysis. So that's going to start with a 20-minute presentation from Optimus, followed by 30 minutes of breakout discussion and a 15-minute report out. At 2:45, we're going to take a 10-minute stretch break. And then Liz, can you jump ahead? Next slide, please. 2:55, we're going to all come back together and do our second set of breakout discussions. And this is going to be around that work ahead to implement our models. We'll have a very brief presentation from HMA to kind of orient us, and it's a complement to the pre-records and the document that our work group members reviewed prior to this meeting. And then we'll dive into 30-minute breakout discussions followed by a report out. And then we'll finish, as we always do, with action items, next steps, and adjourn at 4 o'clock. So without further ado, hopefully we can get started on our, oh, actually, no, I have two more things to tell you. I'm sorry, I was jumping ahead too fast to public comment. Liz, can you advance the screen? I want to just quickly orient us to where we've been and where we're going. So very quickly, last September, a year ago, hard to believe, but a year ago we convened at our first meeting where we kind of laid the foundation for our work together with our charter and getting some grounding and level setting. In December, we focused on discussing and understanding the root causes of the problems with our current healthcare system. In February, the last time we were together in person, that's when we worked together to develop assessment criteria, both qualitative and quantitative, that we're using to assess the models of universal health care. Liz, can you advance the slide? Of course, April was canceled due to coronavirus. We reconvened in June, and this is when we discussed and refined the 3 models that our actuaries are going to have analyzed and will present on today to you. In August, we did some work assessing our 3 models of universal healthcare using our qualitative assessment criteria, and we also finalized some details together on the actuarial analyses. Today, we're here to, again, review the outcomes of the actuarial analyses, and as I mentioned, we're also talking about implementation steps. We've added a meeting, so we actually have 2 meetings in October now. The first meeting in October, which is, I believe, October 7th, we're going to be spending some time, again, really focusing on those implementation steps, the operational regulatory steps that will need to be handled, much of which will happen after our work group sunsets. But we want to be able to articulate next steps. So that will be what we do on that October 7th meeting. Liz, can you advance, please? Our second meeting, which I believe is October 29th, this is when we're going to really just roll up our sleeves and bring it all together and discuss and identify recommendations to the legislature. Then you may remember we've had put another meeting in November, but we've decided to extend that to December so that there's enough time for us to draft the report, get it to our work group members for their review, and then discuss their review and feedback at our meeting in December, and then finally make any final adjustments to our recommendations as needed. So that's where we are in our process. One last thing I want to share with you is our report development schedule, because we're getting into that place where we're really getting all this down on paper. And I'm going to kind of cut to the chase here. We'll share the slide deck with everyone so you can dive into this a little more. But September 22nd, so next week, you're going to receive a revised draft outline of the report for your review and feedback, work group members. You saw it way back in December, but I imagine that's not necessarily in your mind anymore. So we've done some revisions. We're going to send that out to you for your review and feedback. And then at our October 7th meeting, we're going to discuss your feedback on the revised draft outline. In the meantime, our team has been drafting all the background sections and has started pulling together the other sections based on your feedback to date. On October 29th is when, as I said, we're going to get together and identify recommendations, and then the consultant team is going to take that information to draft the remaining sections. You should prepare to receive a draft from us on November 18th. This will be your review draft. It's actually going to be 3 weeks until we get together on December 9th, but there is the Thanksgiving holiday in there, so we wanted to make sure we added an extra week there. And then after we get your feedback, then we'll finish and we'll refine and revise the report for delivery by the end of the year. So again, we'll make sure you have a copy of this timeline, but wanted to give you the heads up so you can think ahead about when you'll have some homework work group members. So without further ado, I wanted to take us to the public comment period. So Liz, can you advance the slide again, please? All right, so since our last meeting, we've refined and clarified some of the rules for public comment. And this was shared with all of the folks who signed up to make a public comment yesterday. So I'm not going to spend too much time on this, although we'll make sure it's posted to the HCA website so you know it. Most of this is pretty straightforward, nothing particularly new, but we did want to make sure we codified this. I also wanted to, and I'll just share for a moment, we had 37 people sign up to make public comment today. We had 20 minutes for the public comment. So I actually made the call this time. You'll see one of my, I have some discretion to shorten the public comment, the time limit for each comment from 2 minutes to something less so that we can accommodate more people. So we're going to do that today, and our commenters were notified yesterday that we're going to shorten it to 90 seconds. So I'm going to ask all of our members who are making comments today to keep your comments to 90 seconds, and that way we can accommodate as many people as possible. As ever, I'm going to call on you in the order in which you signed up. We closed sign up on Monday at 5 p.m. And as I said, 37 people signed up. I am going to be strictly enforcing the timeline. You'll have the timer on your screen, so I'm going to ask you to keep an eye on that. And when it says timeout, please stop speaking so I can call the next person. Remember that if you do not get called on, you do not have an opportunity to make a public comment today, there are ways to share public comments. And all of our work group members get to see it. So there's no difference in terms of work group members getting to see and digest it, whether it's verbal or written. please go to the HCA website to submit public comment if you don't get to do that today verbally. Also, folks who do comment today, if you have any written versions of your comment, please send those in. That really also helps our work group members process and digest what you shared, and we'll make sure that they see it. All right, Liz, can you advance the slide? I'm just going to put on the screen who signed up to comment so you can see. This is the order in which I'm going to call on people. And we have until 1:40, so I'm just going to keep calling on folks until we hit 1:40. And what I'll do, as I did last time, is I'll call 3 names at a time, and that way you can be prepared to make your comment. I have some teammates who are going through the participant list so they can see you. And what they'll do is when your name is called, you'll see a little request to unmute, and turn on your video camera. And then I'll start the timer, and please state your name first. So we're going to get rolling here. Let's start with Gina Owens, followed by David Loud, followed by Sharon Alfaro. And Liz, if you stop sharing, I'm going to go ahead and show the timer.
Jamie, real quick, I think there's a couple folks who are not work group members who are using their video camera. So can you do a reminder again about that? Okay, yes. And I'm going to again request that for those of you who joined late, that if you're not a work group member, if you're a member of the public, unless you're making a public comment, please turn your camera off. It really helps us facilitators track who's in the work group and who's a member of the public. All right, so let's get started. Gina Owens first, followed by David Loud, followed by Sharon Alfaro. So
I don't think Gina is here.
Okay, we don't see Gina. All right, then we'll go with David Loud, followed by Sharon Alfaro, followed by Catherine Lewandowski.
Hello, David Loud. I worked in healthcare for 46 years, the last 10 for Congressman Jim McDermott. I want to highlight proposed federal legislation to help states that want to achieve universal health care. The State-Based Universal Health Care Act, H.R. 5010. It was introduced by McDermott in 2015, by Pramila Jayapal in 2018, and by Ro Khanna in 2019. It will be reintroduced in 2021. The bill adds a waiver provision to the ACA for states or groups of states to control their portion of the funds for Medicare, Medicaid, CHIP, federal employee health benefits, TRICARE, and ACA funds associated with the health benefit exchanges. It also provides for an ERISA waiver so that self-insured companies could not opt out of state plans. In 2021, we hope to make real progress in DC towards universal health care. Medicare for all would be the most economical solution, but it will probably take a while to overcome opposition from the medical industry. But COVID will still be with us, with its triple crises of public health, economic collapse, and racial inequity, all compounded by climate change. The urgent need for universal access can help us move Congress to pass the State-Based Universal Health Care Act so that states that are ready can lead the way. This work group can help Washington be one of those states. Thank you.
Okay, good timing. So next up is Sharon Alfaro, followed by Catherine Lewandowski, followed by Kim Abbey.
I'm sorry, the baby was kind of acting up. What am I supposed to say?
Oh, is it Sharon? Sharon, just to say your name, and then you may start your comment.
I'm Sharon Alfaro. I am a youth partner here at Lincoln Community Services. I'm just here to kind of like watch and learn more and try to be more involved.
Okay, did you have a public comment, Sharon?
No, I didn't.
Okay, great, thank you. We're glad you're here. Thank you for joining us. Next up, we have Catherine Lewandowski, followed by Kim Abbey, followed by Pamela Dalen. Catherine Lewandowski.
I don't see Catherine here.
Okay. And Catherine or Gina, if we miss you, just please send us a chat and we'll come back to you. Okay, so we'll come up with Kim Abbey, followed by Pamela Dalen, followed by Christina Lopez.
Hello, my name is Kim Abbey, and I'm giving a public comment regarding my family's situation. and the faults of employee-based medical coverage. My son has a 10-year career in commercial groceries. He's climbed the ladder to assistant manager. He and his wife, with one 4-year-old, have had full coverage through Kaiser Permanente for these whole 10 years until May of 2020. The multi-state grocery corporation suddenly switched from Kaiser to Blue Shield. The family had developed relationships with their pediatrician and their family practice providers, and then they were forced to find all new providers. And they have found Blue Shield requires copays and deductibles. In just 4 months, they've accrued medical debt that they did not have prior to May. Families lose their choices when employers make one-sided choices for them. So I support government-funded, privately delivered universal health care for all. Thank you for this time to give my testimony. Thank you.
Thank you. Next up is Pamela Dalen, followed by Christina Lopez, followed by Maureen Brink-Lund. Pamela Dalen.
Thank you. I'm Pam Dolan. I'm a registered nurse. I've been working with healthcare as a human right and North Seattle Progressives to change the way we get healthcare. I speak today in favor of option A without cost sharing beyond the premiums. The topic of barriers, especially legislative barriers, is an important one. We can overcome these barriers and we will overcome them when people understand the costs involved in our fractured system of high profits and cost sharing that discourages and often even forbids people to seek health care. This is especially relevant during COVID pandemic. Yesterday at Representative Jayapal's Medicare for All caucus, we learned that Canada has had 25 deaths per 100,000 people, while the US has had 60 deaths per 100,000 people, according to Johns Hopkins data. Professor Karen Palmer, Canada's Simon Fraser of Simon University, attributes this success in great part to Canada's public health system. Specifically, there are no copays, deductibles of cost sharing, or cost sharing that creates barriers to care. I would like to know, we need to find out what the percentage of cost to our state is to use the managed care administered companies and compare that with cost to administering Medicare nationally.
Thank you, Pam. Thank you. Next up is Christina Lopez, followed by Maureen Brink-Lund, followed by Marcia Stedman.
Don't see Christina.
Okay. Christina, if we missed you, please just send us a chat and we'll come back to you. Maureen Brink-Lund, followed by Marcia, followed by, okay, if you're not speaking, please keep your mic on mute. Okay, Maureen Brink-Lund, followed by Marcia Stedman, followed by Kathleen Randall. Maureen?
Hi, thank you. My name is Maureen Brink-Lund, and I'm a volunteer with North Seattle Progressives as well, but I've long been concerned about access to medical care in our country. I've had the good fortune of having good health and good access to care. So surprisingly, because I haven't always had enough money to pay for care, but I really want to speak out for option A. I think all these attempts to collect any kind of money from people to reach their health care is counterproductive. It costs more money to administer those programs. People resist seeking the care they need because of these small amounts of money that they can't conjure up when they need the care. Ends up costing us more in the long run. And so there's no need for us to build in barriers for people to access care. My community is filled with people who are homeless, and some of this in part may have been caused by their inability to access health care or to run into bankruptcy because of medical costs. This doesn't happen in the rest of the world. And I'm really pleased that this work group is tackling this problem, and I really want to speak out for access being as easy as possible for all of us. This virus has shown us that all of us are healthier and all of us are in danger if other people are without health care. Thanks.
Thank you. Next up is Marcia Stedman, followed by Kathleen Randall, followed by Sherry McAvoy. Go ahead, Marcia.
Thank you. My name is Marcia Stedman, and I'm president of the board of directors of Healthcare for All Washington. Back in 2018, the last year for which we have statistics, 52% of health coverage in Washington was provided by employers. Now, hundreds of thousands of workers have lost their jobs, and along with that, their health insurance. Not only that, during the pandemic, many jobs have become automated. Based on evidence from the past 2009 Great Recession, this trend is expected to continue on into the recovery when we do recover from this pandemic. Now, in past work group meetings, there was broad agreement that Model A, universal healthcare that is publicly administered and funded, was the best met the 5 of the 6 assessment criteria. The coronavirus pandemic is disrupting all sectors of our society. Feasibility was the outlier in that critique of the criteria. Does it make sense to link health coverage to employment? In a pandemic, should we use the same yardstick to measure feasibility? Even though there may be challenges in setting it up, a more sustainable, universal healthcare system is a necessary prerequisite for getting our lives back to normal, our economy moving again, and improving public health in Washington. I urge you not to let the feasibility of the past become the enemy of sound public policy today. Thank you.
Thank you, Marcia. Next up is Kathleen Randall, followed by Sherry McAvoy, followed by Cindy Laws.
I don't see Kathleen or Sherry.
Okay, so Gina Owens, Catherine Lewandowski, Christina Lopez, Kathleen Randall, and Sherry McAvoy. If you are here, please just send us a chat and we'll circle back to you. Cindy Laws.
Hi, I'm Cindy Laws. I want to thank everyone for being involved with this project. One of the things I was concerned about is continuing to send around the RAND report. The RAND report was produced several years ago. The research on it was done in 2016. It seems that relying on old research based on another state is not the best, most innovative look at things. So I'm hoping that it's just kind of used as a parking lot there. But one of the other things I'm concerned about is the discussion about feasibility and people being concerned about whether we should or should not do something based on their perception of whether it's feasible or not. And back in 1990, I went to work in the United States Senate, and the discussion at that point in the United States Senate was about the innovative work that had been done in the state of Washington with the passage of the Basic Health Plan. Washington State was the first to do that. We had the Gardner Commission, which was convened later that year in 1990, and worked on healthcare substantially. And they recommended, initially, the vote was for a universal, publicly funded universal healthcare system, but they chickened out. That was 30 years ago, and now we are 200,000 people dead. We have to find the courage and quit worrying about feasibility right now and do what is right, and that is coming up with a very solid plan.
Thank you. All right, next up is Sheila Hoff, followed by Mike Benefiel, followed by Representative Seth Armstrong, retired. Sheila?
I don't see Sheila.
Okay, Sheila, please chat with us if you are here and we missed you, and we'll get back to you. So Mike Benefiel, followed by Representative Seth Armstrong, followed by David Harrow. Mike? Mike, we can't hear you. Can you put your mic closer to your face?
Yeah, okay. Can you hear me now?
Not very well. I'll tell you what, Mike, How about, we'll give you a minute to work on your mic. How about if I take another commenter and then we'll come right back to you, okay? All right. Let's take Representative Seth Armstrong, followed by David Harrow, and then we'll come back to Mike Benefiel.
I don't see Seth, Representative Seth, or David Harrow.
Okay, let's take Rich Legg, followed by Jeffrey Denton, and then we'll come back to Mike. Rich?
Hello, this is Rich Legue. I'm a retired physical therapist.
Thank you.
I've been, over my career, I've seen the problems with our healthcare funding, financing of our healthcare system become worse with increased cost, increased problems with access, and just levels of stress for patients just going through the roof, where people always have to worry about, do they have health insurance? Do they have enough health insurance? Can they see their doctors? It just goes on, and then there's this long history of kind of what I think of as business school fixes, where they're gonna, change the incentives in some way to try to make the current system work, and inevitably those fixes do not work. They just give the current people that are making all the money more chances to game the system to make more money. So I think that we need to really decide once and for all, is healthcare a right or not? And if it is, then we need to be very clear that we need to implement the simplest solution, which is a single payer system that covers everyone. And I think whatever we do in terms of the plan that's produced, we should be very clear that our goal is to get to that single payer system that is going to be the most efficient for everyone. So thank you very much.
Thank you. Okay, let's go to Jeffrey Denton, and then we'll come back to Mike.
I don't see Jeffrey.
Okay, let's try, and again, forgive me for mispronunciation, Raiden McGregor, and then we'll go back to Mike. I know I saw Raiden here. Raiden, you want to go ahead?
I'm not able to unmute him.
Freaking out at me, so are you able to hear me?
Yes. Can you turn on your video camera too?
Yes.
There we go.
Yes.
Great. Wonderful.
All right.
Thank you.
So I've not been involved. First of all, thank you for the opportunity. I've not been involved in any of previous discussion. So these are the points I just want in your heads as you proceed forward. One, healthcare is a human right. I have a genetic condition that my now 2 adult children over age 26 also inherited. But our access to diagnostics and treatment is different depending upon the insurance. This is absurd. I'm trying to pull myself together. I don't have the freedom to pursue my true potential as a person because I'm locked to a job because I have to have health insurance. That's entrapment of sorts. No corporation, CEO, or medical organization should be profiting off of my genetic misfortune. The capitalistic structure for healthcare is morally wrong. Universal single health payer system that's government funded is the most logical and fair approach to ensuring healthcare as a right is received. People are dying right now, have been, and will continue to die because of the lack of access to healthcare. A person's existence should be all that is required to receive healthcare, the same level and quality regardless of financial status. And I support a government-funded healthcare system, and I'm sorry, I'm upset. Thank you.
Thank you. Okay, next up is, we'll go back to Mike Benefiel, and then followed by Mark Prue, and we should have time for one more, Roxanne Thayer. So, Mike, let's see if your mic works this time.
Can you hear me?
Why don't you use your outdoor voice, and hopefully we'll be able to hear you.
My what voice?
Your outdoor voice. Speak real loud.
Okay. I'm Mike Benefiel from the 23rd Legislative District, and I'm a member of Whole Washington. I believe the goal of this work group is to provide the legislature a recommendation for not just universal health care, but for affordable, comprehensive universal health care. Anything less will continue the needless suffering and deaths we are seeing with our families and friends. The chairs of both House healthcare committees in the legislature told us that implementation of Cascade Care would achieve universal health care for the state of Washington. Their vision of universal health care doesn't help anyone. There is only one solution, one option, and all of the modern world knows it. That is a single payer healthcare system where the government pays providers directly and the profits of the insurance corporations are eliminated. I recommend that this work group provide only one option to the legislature, a single payer system. Any other option will delay the help the people of the state of Washington need. I would add that the phase-in period be short and dictated in the bill and not left to future legislation. Thank you very much.
Thank you. Okay, I believe we have time for two more, so we'll take Mark Prue, followed by Roxanne Thayer. Mark?
Good afternoon. I'm Mark Prue, and I'm with Whole Washington. I appear before you today to urge you to adopt Alternative A to help establish in Washington the first ever not-for-profit single-payer health care system in the United States. Advocates for universal health care often derive their motivation from one or more tragic, financially devastating experiences with the existing system. I am not one of those people. I am fortunate to have been blessed with good health and excellent insurance. Although my experiences have been positive, I am well aware that one illness could prove catastrophic. Though I may have little to gain or lose from implementation of universal health care, my advocacy is based on the fact that my situation is the result of good fortune and nothing more. I am no more deserving of good health care than someone who lacks the financial means, familial connections, good health, or just plain luck to avail themselves of high quality insurance. Reliance on chance as the principal mechanism for allocating health care is a profound injustice that must be remedied. In short, health care is a human right. Washington can lead our nation in granting that right to everyone by adopting Alternative A, the alternative grounded in economic and social justice. You can help us get there. Thank you for your time.
Thank you. Okay, last up is Roxanne Thayer.
Hello. Hello. My name is Dr. Roxanne Thayer, and I was a high school principal at a Title I high school. I had a student who was barely on his feet. He went through 1 year and kind of pulled himself together. He was gifted, and he applied for a scholarship to the Bangor Naval Submarine Base as a internship in the summer. It was the first time that the engineers who interviewed for that position could agree on one student. This is the student. This is his Naval Submarine Base identification that the engineers gave to me. And his father was on disability, and for some reason the disability was removed. That disability allowed him to insure his sons. They felt ashamed and didn't come forward to say they needed help with health insurance. That young man died. At his funeral, the engineers of the Naval Submarine Base cried. So did everyone else. We lost a young life because he did not have health insurance. And that's just one of many who have died. My sister's Canadian, and in Canada, that would never have happened. Thank you for this time.
Thank you. Thank you, Dr. Thayer. Okay, that concludes our public comment period. Again, a reminder to those of you who either were called on but weren't here, maybe have joined us now, or those who did not get called on today, please do go to the HCA Universal Healthcare website and submit written comments, and we will ensure that our work group members receive them and have an opportunity to review them. And to everyone who took the time to make comment, share your personal stories today, thank you for that. We really appreciate it. I would also be interested to hear feedback through our website if you prefer to have the comment on the front end or the back end of the meeting. So please do share feedback if you have it. And thank you again. I'm going to remind all of our members of the public to please turn your video cameras off now and mute your mics for the duration of the meeting. And I'm going to ask the members of our work group to make sure your video cameras are on. And I'll stop sharing the timer so you can see each other better. So now we are at the point in our agenda, we're going to turn it over to our actuaries. As I said in our intro earlier, this is, I think, the moment many of you have been waiting for. And so our actuaries are going to do a brief presentation, about 20 minutes, and then we're going to move into our 2 breakout groups, and I'll give you some instructions when that gets started. So Shane, Jared, on to you now.
Great, thank you very much. 1 second here and I will get the PowerPoint loaded. Great, and can everyone see the PowerPoint?
Mm-hmm.
Great, thank you very much. Well, hello everyone. It's exciting to be here today. We've spent a lot of time working on these models, and clearly this is impactful work, and we're really excited to share the results. My name is Shane Mofford. I'm a consultant with the actuarial consulting firm Optimus, and Jared and I are going to walk you through the modeling that has been done to date. Our goal is to ensure that you understand the general approach we're taking to modeling the cost of implementing a universal health model, to give you a general understanding of the current lay of the land, and to highlight how input from the work group has shaped the analysis. We are going
Shane,
to
can I just interrupt you for a sec? Sorry, what we're seeing on the screen is actually your
my notes,
not the full presentation slides. Sorry, for those people who have small screens, I think it might be hard for them to see it.
Sorry, Jamie, what are you seeing?
We're seeing the presentation, not the full presentation screen. We're seeing your screen with your next slide and notes. Thank you for fixing that.
Is that better? Can you see the correct one?
I think it's the same, but I'll tell you what, hopefully everyone can still see it at least a little bit. So just go ahead. That's all right. We've got the slide deck. We'll post the slide decks to the website so folks can follow up and take them.
All right. So let's see here. We're going to cover a lot in 20 minutes. No, a little less. We'll be heading into the breakout groups where we can answer clarifying questions and discuss the models in greater detail. I want to lead with the conclusion so that we're not keeping anyone in suspense. Similar to other studies, we do find that moving to a universal healthcare model is likely to generate significant savings. I will, however, note that our model results are for the first year of implementation, and the amount of savings potential in the first year compared to longer term viability of the model is quite a bit less. Further, our analysis highlighted numerous operational implementation and financing considerations that we'll need to tackle with the work group in future meetings. So let's dive in here. So the healthcare system is massive and it's complex. So how do you estimate the cost of moving to universal healthcare? That's a great question. So the way that we tackle this is that we are essentially using 2 different strategies. The 2 different strategies include one where we first build an approximation of current state expenditures by population, and then make incremental adjustments to the expenditure based on all of the different expected impacts from transitioning to a universal healthcare model. An example of this type of incremental impact would be to reduce the expenses associated with hospital utilization for the Medicaid population due to increased access to primary care as a result of the price difference between Medicaid and commercial insurance going away. The second strategy is to build the new system from the bottom up based on estimated per person cost and anticipated enrollment. We use these strategies together to triangulate our best estimate for the total cost. We are going to focus on the first strategy, as this strategy provides a lot more insight into some of the major transition considerations than a basic build from the ground up estimate of cost would. This slide illustrates the high-level process by which we build a model of current state and then adjust it to get to our universal healthcare cost estimates. We start by identifying all of the different payer sources and expenditures in the state. We use data for calendar year 2018 as our starting place. We apply trends to the calendar year 2018 data to get to an estimate of the 2022 status quo expenditure. We then apply the incremental adjustments I previously described to get to a final expenditure estimate under each of the models. So let's talk about the 2018 data inputs. The Office of the Actuary in the Centers for Medicare and Medicaid Services produce annual estimates of national healthcare expenditure for all of the major healthcare payer types, including out-of-pocket expense and other non-insurance expenditures that would be covered under the universal healthcare model, such as out-of-pocket expenditures. We use the same framework and similar categorization as the national resource, but we also use other sources of data from the state Medicaid agency, official reports from CMS, and more. We do that to ensure that where we do not have reliable data, or excuse me, that where we do have reliable data, we're using it, and not just using national estimates to extrapolate results. Where there is quote unquote verified expenditure that was not readily available, we do exactly that. We actually impute the results to get an estimate of cost for those categories. Again, out-of-pocket expenses is a good example of that. So based on that process, our best estimate of total healthcare expenditures for Washington in 2018 were the types of expenditures that would be captured under the universal healthcare model, a little over $60 billion with a B dollars. Of that amount, approximately 56% is data that we have firm numbers on from multiple sources, and 44% is imputed. That is to say that it's estimated based off of national statistics. I would also note that we have excluded some categories that are included in the national estimates because we do not think that they would be folded into the universal healthcare model. This includes things such as research, investment, and some of the costs associated with public health. Funding for those services would remain intact, just not part of the model. I want to point out that having to impute 44% of the expenditures in the model is quite a lot. We'll talk about why that is the case in a moment and what some of the implications are. So this slide shows our estimates of the top 5 largest payer sources from the total $60+ billion. The pillars in green reflect expenditures that we could validate through multiple public sources, while the pillars in blue reflect imputed estimates based on national statistics. The top 5 categories listed here are out-of-pocket, reported private health insurance, imputed private health insurance, Medicare and Title 19 Medicaid. National statistics suggest that approximately 11% of total personal health care expenditures are out-of-pocket. This is important because the work group has requested that the initial model should not include cost sharing. That means that these costs are folded into the model versus remaining a cost that the patients pay directly. We do make assumptions about changes in utilization associated with removing cost sharing, so there is some nuance to that broad statement. Another important category that we had to extrapolate was private health insurance. This includes self-funded employer plans that are subject to unique federal regulations or ERISA plans. These were actually mentioned in the public commentary. The state has limited ability to impose reporting requirements on these types of insurance. This next slide shows you all of the other payer sources that are contemplated in that $60 billion estimate. The red bars, however, are categories of expenditure that we have not included in the model. What I want to note, and a key point here, is that the scales on these 2 different slides are different, that this entire set of multiple different bars actually represent a fairly small proportion of the total expenditure in that $60 billion.
Shane, sorry to interrupt you. We have a hand up from one of our workgroup members. Would you like to take questions now, or would you like to get through the presentation? and then take questions? What's your preference?
So we'll be going into breakout groups after the 20-minute presentation, and we can take questions at that time if we have things that need to be
okay. So Kelly and other members of our work group, if you could hold your questions until we move into breakouts. There's going to be an actuary in each of the rooms, and they'll be able to answer all of your questions there, and then we can also share them across breakouts of the report out. Apologies for interrupting, Shane. Go ahead.
Oh, not a problem. Thank you very much. Okay, so ultimately we're looking at this question of, do the cost decreases associated with universal healthcare offset the cost increases? And within that, we're looking at a combination of balancing factors. So we have factors that increase the short-term cost. Those include adding covered populations, presumably that if someone didn't have coverage before, and now they do, their utilization patterns will change. Covered benefits, removal of cost sharing could have an impact on utilization as well. Factors that decrease short-term cost include greater financial leverage from a single plan, reduced administrative costs, and economies of scale.
Shane, sorry to interrupt again. I think part of the problem is that folks can't see the slides very well, so I think we need to address the settings. I apologize for putting you in the middle. I think if you go to display settings, it might fix it. I know we had it in the tech check, it looked okay. So just take a minute and make it work. I know you can because you did it before. So thanks everybody for your patience.
Hi Shane, this is New York Liz. If you don't mind hovering over display settings, yep, and then click the first option that you'll get. Yep, swap presenter view and slideshow. Correct. That should work. There you go. Perfect.
Okay, thank you.
Thank you, Shane.
No, thank you. Sorry about that, everyone. As mentioned, we'll have these slides available online, and you can also review the recorded presentation to match the two if you need. Okay, so we just covered the fact that we essentially have both increases and decreases that are accounted for within the model. And ultimately, that leads us to a conclusion in aggregate, and I'll run you through those now. So a few things I want to cover here. Key to interpreting that, for the categories of care and populations included in the model, we estimate that our starting place is between 55 and 58 billion in 2022. And this is a large range, and necessarily so. While it's maybe not large in terms of percentages, it certainly is in a magnitude. There are really two factors driving this. The first is that the range, there's a range of assumptions for growth rates. And the second is that there is a degree of uncertainty introduced when you're imputing the large amounts of expenditure that we talked about previously. For the close the gap model, we've essentially assumed current state policy with cascade care, subsidies, all of that will continue as planned, and that the significant change here is that we would add coverage for undocumented immigrants. So just for simplicity, we're showing only the incremental new cost for that particular model. So in the bottom row, we are showing the incremental change in system cost. This is a 1-year impact, assuming 2022 levels of expenditure. And the way to interpret these preliminary incremental results is the change in total healthcare system cost after accounting for changes in utilization and capturing efficiencies. I want to reiterate that these are purely cost. The estimate does not make any consideration for premiums, and it doesn't make any consideration for changes in federal revenue, such as what may happen with Medicaid. Now, some very key notes. In addition to these different excluded categories I discussed previously, we're also assuming that Medicare is not included, but that Medicaid would be. This is an assumption we can change, but we believe it to be the current direct. Also, these estimates currently include covering dental and vision for everyone under the plan. It includes the existing long-term care costs in the system, such as those covered by Medicaid, but it does not include the incremental new costs that would stem from providing access to long-term care services and supports more broadly, whatever new incremental increase in utilization would occur. And one last very important note, while these figures do not account for revenue, they do account for the fact that the current premium tax and statute would not apply under Model A, but it would under Model B and C. What that means is that a portion of the cost savings are lower tax, but it also means that the state may need to solve for backfilling that lost revenue. And so the results themselves, that the aggregate incremental impact for the state administered model, we're anticipating that in the first year, it would be possible to achieve global aggregate savings of $461 million to $3 billion in savings. So it's, again, a fairly large range, but there are a lot of assumptions that go into making that in terms of what's possible. And again, a portion of that is attributable to a loss in premium tax. For the delegated administration model, after pulling in all of these new costs for expanded benefits and new populations, we anticipate that it could be approximately neutral, that total system costs wouldn't change. So you're getting more access to services, but you are actually not increasing total costs because you're capturing some efficiencies as well. However, at the high end of the estimate, it could cost as much as $2.6 billion more. For the close the gap model, just to cover the undocumented immigrant population, we're estimating that it would be a cost of approximately $400 to $600 million. So that's a really high level overview of the strategy that we took to develop these estimates, what type of data was used, some of the big assumptions about the types of utilization that flow into it, and what the aggregate results are, just looking at cost and without any consideration for feasibility, any consideration for revenue sources, premiums, or anything like that. And going into that are a lot of different factors, and I'm going to kick it off to Jared to run through some of the incremental impacts to help you understand what some of the underlying assumptions are.
Thanks, Shane. So I'm Jared Nason. I'm also with Optimus. What I'm going to walk you through now, in a little bit quick fashion, I suppose, is the details behind some of the assumptions. So I'm not going to spend a lot of time on each one of these because we simply don't have the time. So I'm going to go through this really quickly. This slide here, what it presents for you is more or less an itemized impact, or a range of impacts, if you would, for some of the assumptions that were made in the preliminary estimate. I do want to stress before I move off this slide that the values that you see on this slide are not additive, and that they are connected. So if you make a change in one spot, or make a change in one assumption related to who's covered, what's covered, you're going to see changes throughout. So please don't view it as additive. Go ahead and move forward for me, Shane. Thank you. So as we jump through this slide, what we want to focus on is which model has, which assumptions have the greatest impact, and does seeing this information change your perception or change some of your thinking behind some of the design elements. And we'll discuss that during our breakout sessions following this discussion. Go ahead. I'm not going to go through this in detail, but this kind of lays out for you who is included and who is excluded. This dovetails to the slide that Shane went through in terms of the data sources themselves. But I do think that the key thing to take away from this slide is that the more programs or the more populations that we do include, of course, greater progress towards the goal. Also, it increases the complexity and the implementation considerations. And so really a question for the work group members is, do you still agree with the current assumptions that we have for the included populations? Something we'll talk about in our breakout discussions. Thanks, Shane. You can move forward. So I do want to highlight, I can't go through in detail, unfortunately, because we just simply don't have the time, but we have made assumptions for including dental, including the coverage of vision. That includes eyeglasses, frames, contact lenses, et cetera. At this moment, the model does not include long-term care. It is something that we were working through, but at the place we were in the timing we had, we were not able to present the assumption for you. But I do want to say, from a dental standpoint, NHE had its own category for dental, which was great because you could see what the expenditures were. But in looking at that, what we decided the best way to approach this would be is just to remove all of that completely and try to build it up as a little bit of a what it would look like based on a standard HMO PPO type model for dental, and that's the basis for the assumption. On the vision side, we don't have NHE as its own service category, so in this regard, we had to look at it as, okay, of the population, and we focused on those that are 45 and older, what population has a vision need? How many of those folks then actually have dental coverage currently, and therefore would need assistance, or we would see cost increases associated with out-of-pocket, covering out-of-pocket costs, and then breaking it into the population who don't have vision but would need coverage. And so that's how we thought about the vision component, at least from an expenditure projection standpoint. Shane, go ahead. Okay, so high level, Shane's already covered this, that the universal healthcare model looks, from a cost sharing standpoint, is going to be a substantial outlay of all of the assumptions that we are making to cost anywhere between 4.7 and 5.5 billion. At this point in time, the work group from our last discussion has made it clear that they wanted us to not incorporate cost sharing in any regards, and so that's the impact here. I do want to highlight in this circumstance is, it does eliminate the potential barriers in access to care. It will, the potential for short-term access limitations and longer-term care savings are there because you are increasing access to the medical necessity. So this is an impact that you might see a greater savings number in the future beyond what we've presented here. And then the closing the gap is just simply the same as what is in the public options. Okay. So the provider payment, this is another big component of the impacts here. So this is based on capturing rate reductions in the model. So the rate reductions are aimed to be somewhere between Medicare and commercial, but right now as it's modeled is trying to maintain aggregate revenue neutral approach, meaning that we want to see changes in reimbursement levels where commercial would come down and Medicaid and other payers would go up. And so what we're expecting is kind of an aggregate revenue from a provider perspective, not from a program expenditure perspective. I do want to note that this is a range here because the state may be forced or through deliberations with this to compromise on what we have modeled here from a rate reduction standpoint. So therefore you have a range. And then lastly, as Shane noted, we do lack some information on a good chunk of the information that we're using for our projections. So we do expect some variation to occur as it pertains to what the actual provider reimbursement efficiencies would look like. But we do recognize in this that the providers themselves, through consolidating to a single payer or reducing to a small number of payers, it should reduce or should result in some efficiencies for the provider themselves. Okay, Shane? So administration, a big component here. So from a state standpoint, if the state is to administer this, the biggest savings is that you eliminate more or less the expenditures that are paid today in current state for insurance companies, HMOs, et cetera. However, I do want to note as part of this, there are implementation costs that are not currently contemplated in our modeling for setting up and establishing a state administered system. So that runs the gamut of doing claims payment eligibility, infrastructure, regulatory framework. And then as we go into a delegated administered model, this is that option B, where it might be contracted, and the responsibilities that are going to be contracted out, I think we've talked about in prior discussions in terms of variance between provider networks. Will the insurers negotiate their own rates with the payers? I think those are some of the outstanding issues as it pertains to the delegated administrative proportion or the option. But then as we get into this, we do, again, we do recognize that there will be some economies of scale as it pertains to administering the system. You would in theory no longer need to have an exchange group at the authority, a PEB group at the authority, a Medicaid group at the authority, et cetera. You could consolidate some of those functions and redirect maybe some of those dollars into some of the actual go live implementation component of a universal healthcare system. Okay. Okay, so finally, just keeping in mind, this is a lot of information to absorb, so I totally understand. The model we do have some data gaps. And one of the things we do need to think about is how you transition to universal health care. You want to make sure it's safe in regards from a financial perspective. States are not allowed to go into deficit spending, and as such, if you're running a state-administered model, you would need to make sure that there's adequate tax dollars to pay for the system. We need to think about the implementation timeline, and what I mean by that is what are the decisions that need to be thought out in terms of a policy, and also what is the cadence? You can't certainly make a decision to say, for a simple example, that we're going to include Medicaid or we're going to do a block grant right now to make sure that we can retain all of our funding, but then forget about the fact that we're going to need to reimburse, or we're going to need to change some of the levels of reimbursement. So you want to make sure that you're staging this in the right fashion. As you think about the operational design, this is the revenue sources and the current funding mechanisms. There is a lot of nuanced funding mechanisms that exist in the system today to make it work the way it does today. So you would have to wind those down. You'd have to either find replacements or find a new mechanism in order to maintain those revenues. And you'd also have to accommodate for the transitional costs associated with building a new system. And then lastly, who knows what's going to happen from a federal perspective. I mean, it's possible, likely, under a future administration, and it may make this more feasible in the long run. So having said that, I want to just close by saying, Shane, last slide, that as we proceed from this point, we're not done with our modeling. We still have more refinements to make. We do have to address revenue offsets and new revenue needs and identifying those. And then also, as part of this, I think it's appropriate to identify any sort of nuanced policy decisions or operational decisions that are going to need to be considered by the policymakers as we make the recommendation going forward. And so those are our next steps. Thanks, Shane.
Okay. Liz and I were just chatting on the virtual chat, and we're going to propose just a minor amendment to our approach. We were originally going to go right into breakout groups, but we're thinking, especially given that you may not have been able to see some of the earlier slides, that it might be useful to spend some time all together here so that you can all hear each other's questions, and Shane and Jared can answer those. And then we can go into breakout groups and hear your feedback. So why don't we start with that? I imagine you have a number of clarifying questions. So first of all, work group members, if you could all turn your videos on, if you turned it off during the presentation. And then a reminder to our members of the public to please turn your video cameras and your mics on, video cameras off and your mics on mute, please. All right, I see a hand up from, oh, before I call on you, Aaron, I saw a request, and yes, we will distribute the slide decks from today to you. And in fact, I will just make a quick email out to all of you so that those of you who want to refer to it right now, you can take a look while Aaron's asking his question. So Aaron, you're up first.
Okay.
Let's see if we can get him unmuted here.
Myself.
Give it on mute.
Okay,
there we
got
go.
it.
Thank you.
Well, thanks for that high-speed review. I mean, I've got 1,000 questions, but just one. On the slide where it had the baseline, and then I think some net incremental savings or whatever. I don't understand why the baseline for options A and B would be different than option C. I mean, the baseline, your estimate of $60 billion would be the same for all three models. No, so I didn't quite get that.
Yeah, I can clarify. That's a good question. So the way that we're defining the baseline is for all included programs that would be replaced by the model. And what that means is essentially all of your Medicaid expenditures, all of your essentially commercial expenditure. The subset that we're considering as part of the model actually is different between models A and B, which are the same, and model C. C is essentially current subsidy policy, plus the incremental addition of allowing access for the undocumented population. So there are several different ways that you could characterize it, but just to help you understand, we're defining it based off of the programs that are essentially subsumed by the universal healthcare model.
Okay, I see Kelly has her hand up. Kelly.
Okay, I think I'm on, right? Yeah.
You are, yeah.
I was wondering, it seemed like there was a critical slide missing that really would have made this decision more helpful for me. And that was a slide that just delineated those assumptions that were talked about. Or it might have been, maybe it was on a slide that I couldn't read, but yeah, there was a whole verbal listing of assumptions that were made, and it was kind of hard to track it all. So I'm wondering, could we get a slide of that?
Shane, can you share your slides again? And Jamie just sent out the PDF of the slides, and I'm going to try to send it to you guys via Zoom as well.
Do you think that that was in there, Shane?
There's two aspects to that. So we talked about the high level concepts of the types of adjustments that were made in the model and then showed the range that's with them. And I think what you're asking for is slightly different, that you would like to know like the percentage decrease assumed in admin and the percentage decrease assumed.
Eventually, that would be great, but even just the listing of the general bullet points that you covered in what you were talking would be great.
Okay, so
there was one slide that you lingered on it a really long time, and it had like 3 variations, and then you were listing really great information, but I, being a visual person, wanted to see it laid out.
Okay, so
make sure that I was understanding and I could ask you good questions about it.
Yeah, no, that's a good point. So the incremental impacts of the high level adjustments, Jared covered that on the first slide of his presentation. And that's where it had the broad ranges. We do not have in the slide deck anything that itemizes the underlying assumption that produces those results. So that's not in the slide deck. So to the extent that you would want that information, that's certainly the type of thing that will be included in the report, and we can look at providing information about the assumptions that underlie the impacts to the work group members as well in the future.
That would be great, and I realize they might change over time, but just, you know, so that we make sure we're talking about the same things.
Yeah, there is a complicating factor that I think it's important to recognize, which is that all of these things actually interact and compound. And so to show the incremental piece of it's actually a little bit challenging because if you cover a new population, your admin assumption may change. So we'll have to give some thought in how to provide some really good, meaningful information that conveys what we're assuming in the model. But I hear and understand your question, certainly.
So it's almost like a web then, in a way, right? Yeah.
Yes, a lot of things are connected.
Yeah.
Thank you.
Okay, I see Aaron followed by Dr. Kovar. Aaron?
Yeah, I just a note on the slide that you showed all of the different sort of programs that are excluded from the model. You know, given the presentation about the federal legislation that David Loud made earlier, I think that's one of the areas that we're going to want to talk, especially Medicare. So just to note that we'll want to be discussing that list of programs.
Yeah, that certainly makes sense. And I know that our future presentations and conversations with you will be talking about feasibility, and there is an intersection there in terms of regulatory authority, lift to execute, and what should be included in the model. So I think we'll definitely get into the meat of that in future presentations.
Thank you. Okay, Dr. Kovar followed by Dr. Tritko. Dr. Kovar. Able to unmute there? There you go.
Similar
Good.
to the comment about intersectionality,
Dr. Kovar, can you come a little closer to your mic? We can't hear you very well.
Yeah. So Shane, in an early slide, you included for offsets, the Indian Health Service resources. And just maybe you could comment how is that feasible? Same way we're leaving out Medicare from the model. And then just quickly, the whole issue of, in terms of offsets, is trying to get started with quantifying it. How do you look at, or how do you not look at issues like estimating savings from costly ER utilization for uninsured people and trying to put some kind of price tag on that as we try to communicate redistributing this whole thing rather than adding costs.
So to the first question, thank you, regarding Indian Health, the way that it's captured in the model, at least in part, and I would just note it's important to keep in mind relative magnitudes here. Indian Health Services is a fraction of 1% in our total model. But we thought it was important to capture because programs like Medicaid can cover Native American folk, and they claim that program's match as well. But not all expenditures would be captured per se. So I think that's actually an area where we need to refine some of our assumptions. But just note that we do need to capture it to the extent that it might be folded up in another program.
I'm going to go a little bit out of order here because I saw Vicki responding to something Shane said, and I suspect that there's some additional information she can provide from her experience. And I also just want to remind folks, we're going to still try to go into breakout discussions. So right now we're just doing clarifying questions, but then we can really dive into your thoughts and feelings and impact and feedback on what you've seen here in our breakout discussions. Vicki?
Jamie, would you like me to address the second question real quick? It's
yeah, sure. Let's have you do that, and then we'll go to Vicki
the second question was about accounting for changes in utilization patterns when people have access to insurance. We do have adjustments for that in the model, increases in utilization of primary care, decreases in types of services associated with exacerbations of conditions. We haven't presented those. We gave kind of like the highlight reel for a lot of the major conceptual adjustments, but those are in the model. Good question.
Okay. So my apologies, Dr. Tricco and Bevan. I'm going to just go out of order here and ask Vicki to step in on the Indian Health question, and then I'll come back to you. Vicki?
Thank you, Jamie. I just want to add that Indian Health Services is payer of last resort based on federal law 42 CFR 13661, and so that's why it should be included. That's the main reason. Thank you.
Okay. So I just want to also communicate, folks, a little. We're flexible here with changes. We're going to make a little change of plans. I'm hearing direction that we should all stay in here for the whole time, and there's actually fewer of us anyway. So I think we can still have a really productive discussion. So don't feel like your wings are clipped. Go ahead, and also we have some questions for you. But right now, let's try to talk about clarifying questions, and then we have some questions to generate some of your feedback shortly. So Dr. Tritko, followed by Bevan, followed by Carrie. Dr. Tritko, thanks for your patience.
I was just wondering about savings of the various plans for underwriting expenses. So most health plans have an underwriting expense. The administration is around 5%. But yet under the Affordable Care Act, they can charge 15 to 20%. That's why ERISA plans tend to be so much cheaper, is that they assume the underwriting risk. But on these, have we looked at the whether we're going to assume underwriting risk in the plans, or are we going to assume that the state in this large pool will be assuming the underwriting risk and therefore have the savings of accepting that risk?
That's a good question.
This is Jared.
Oh, go ahead.
Go ahead. I was going to say, I think you have to. I think we have to think about how it's going to be administered. So if it's a state-administered system with the insurers out of the equation, I don't think you would even have that underwriting charge that you referred to. If it's in a delegated model, I think what we're talking about from a managed care and insurer perspective is you really would want to price it, and the savings would reflect what the actual cost that entity would bear for performing the contractual obligations that you've laid out for them. So if there is no risk per se under the delegated model, where it's just simply they are acting as, for lack of a better, I guess, term, an administrative services only organization where they're paying claims, providing utilization management, et cetera, you're going to see a much lower payment for those functions than if you put them entirely at risk or even partially at risk for some of the financing of that program. So I think it's going to vary pretty substantially.
Yeah, that's a really good point, that there is that variation. It does lead to the decision point from the work group of, do you want to purchase that delegated risk or not? And I think that's what Dr. Tricko is getting at.
Dr. Tricko, do you have a follow-up there?
So just to clarify, so if the state were to assume the risk and have the health plans administer it, you're probably more around the 5% range. If the state were to buy insurance, an insurance product that bears risk, then you're probably going to be paying more of the 15 to 20% range. That is a huge potential savings, and I think if you're talking about millions of people, that the underwriting risk should be pretty small. But I'm sure Jane could talk about this a lot better than I can.
Yeah, and I mean, if it helps, if you think about it, the state does today in this function do just this, for example, through their Medicaid managed care programs. And so I will say, I don't think the admin goes as high as 20. It may not even go up to 15. I can't remember off the top of my head exactly what Apple Health looks like, but within that, you've got some accommodation for some underwriting gain, but your admin could range anywhere from 8 to 11%. And as you add more populations, potentially you gain more economies of scale with that. And you also have a better position in order to dictate profits or gain, if you would, and reduce or hold down insurer margins over time. That's just as an example. I'm not saying that would exactly translate, but as an example.
Okay. Bevan, I'm going to ask you on this thread, because I think Jane might have something to contribute to this topic, but you've been really patient waiting to ask your question. Would you be all right if I let Jane jump in, and then I'll make sure I come to you right after? Okay. All right. Jane, do you have you want to share some additional thoughts on this?
Yeah. So I want to understand. Now I'm going to go back, Jared and Shane, and I want to be sure I understand this. So universal coverage, we're assuming the state's administering, and the state may be contracting with an ASO, right? Do I have that right?
That's a potential option.
Second model.
Yeah.
Okay. Second model, state is contracting with MCOs to administer the program. So are we assuming that those MCOs are not bearing any financial risk at all?
Yeah, let me clarify on that. So the Model A does not assume an ACO structure. It assumes that the state is administering the program and all of the functions with it. You'll also note that the state administered program is significantly cheaper as a result, and it goes back to some of these concepts of underwriting risk and whatnot. Model B, it does have a delegation to managed care entities, and the model, it's currently assuming that they are at risk. That is a decision point, though, for the work group. If you assumed an ACO structure, the amount of administrative costs that would be reduced due to the points that were made previously about underwriting risk.
Okay.
Shane, excuse me, sorry, Jane, I just need to interrupt. For the benefit of our members of the public and maybe some of our work group members who are not following all the acronyms, could you please just clarify ACO and MCO for everybody?
Okay, sorry.
No, that's okay.
That's okay. So first of all, Shane, I think you misunderstood me. So in a single payer state model, the state has a choice as to whether they want to contract with an entity to administer the program, an ASO, an administrative services organization, or a third-party administrator. And thank you, Jamie. In terms of MCO, the Medicaid program contracts with Molina, United, Amerigroup, et cetera, and they call them Medicare managed care organizations. Essentially, they're acting like insurers. They're bearing risk for the enrollees that they take care of. But I guess, so I just a couple of thoughts really quick. On the first model, and I see Representative Macri on here, the thought of the system's gonna need to build in some sort of reserve capacity. right? Because you don't know exactly what your claims experience is going to be. So I'm assuming that you're embedding in your model some level of reserve, some percentage of reserves. And then on the second issue, I agree that it does definitely make a difference as to whether the managed care entities are going to be bearing risk or not. And I mean, Dr. Trico's right, and I think you're all right, that if you have a single purchaser, you have a lot more control over what you want the admin spread to be, what you want medical loss ratio to be. But there's a lot of wiggle room in there in terms of the assumptions.
Right. It's also, I mean, aside from the reserves, if you are at risk, I mean, you've also got to think about any sort of pay down, any sort of liability that's currently outstanding as you roll into that future year. So when you think about what kind of revenues are needed, there's kind of the cost of the system within the current year, but you've also got all those costs that are going to continue to be paid in that year for services and other functions incurred in a prior year or prior period. So yeah, it's a bigger component that is something that on my last slide, I highlighted the risk. You know, we want to get this right. It's going to take a lot of detail, a lot more detail than maybe we have available to us at this point to really pin it down, but it does present a substantial financial risk to the state of not getting it right.
And just to be the acronym explainer, Jane mentioned it, but it was in the middle of other things she was saying. So just to go back over that an ASO is an administrative services organization that could be hired by the state to perform the administrative functions, pay the claims, contract, etc. But it doesn't bear any risk for doing that work. It's just paid a fee for that work. And MCOs are managed care organizations that are providing, that people use as their health plans.
Thank you, Jane and Nora. Bevan, thank you so much for your patience as we wrestled with the last question. Calling on you now, and I'm gonna see if I can unmute you here. There you go.
Yeah, no worries. Can you all hear me? Okay.
Yes.
Okay, great. So just to clarify on the cost, a couple of pieces here. The cost in the first year, 22, is that same cost going to be assumed for each consecutive year? So is that, you know, approximate cost per year to fund the program? Secondly, in terms of the savings, is there a way to break down where those savings are allocated, right? So how much savings from there is allocated to the state versus individuals versus, you know, businesses, et cetera? Is there a way that we can look at those components? And then the third piece is there a way to delineate kind of the cost per, you know, population? Let's say we were to break this into policy proposals. So year one, we include this population. Year two, we include this population, so that as we start to like push on this and advocate for this, and I think from a policymaker perspective, it's helpful too, to understand, you know, incrementally each year, how do we add, or, you know, if we were able to do this one time in 2022, great. But if we can't, like at year one, what does that look like?
Yeah, so three questions there. The first, are the incremental cost savings annual? The answer is no, and the reason for that is that the assumptions look different over time. And let me just give you one really concrete example. So one of the major cost savings assumptions with universal healthcare is that in having access to all of this data, you have the opportunity to be more effective with your fraud detection, and that will drive down costs. However, if you think about this from an operational perspective, where you implement healthcare, you start getting data after you start the program, and then it's going to take several months before you have data to identify patterns of fraud. Then it will take several more months before you can actually pursue that fraud and buy it back. So there is this temporal factor where some of the efficiencies of universal healthcare don't manifest in the first year. So it's very likely that, you know, depending on the strategies and how this is operationalized and how it's implemented, how aggressive the state is in terms of pricing, that the savings could grow over time. The second piece of that, and on this same question, is that there are really big data gaps now. Like, we don't know precisely how much people are paying out of pocket. We don't know precisely how much some of these other contributors to healthcare costs are actually contributing, uncompensated care and whatnot. And the implication of that is that year one, the state's probably going to want to be pretty conservative in its assumptions with provider pricing, or the payments to providers, that you don't want to assume too much savings initially because you have too many unknowns. You could put a lot of companies out of business doing that. So I think that there are multiple factors, some up, some down, that look different in the first year. So that's really just an implementation year cost assessment. And the reality is, how this whole thing is implemented is really going to drive the cost anyhow. So there's a lot of questions that need to be answered before you could start to project beyond this implementation year. Your second question was about distributing savings. And I think it's really important that we're clear on what the savings are exactly. So what they are is that we're looking at every possible contributor of dollars into the system, be it out-of-pocket expense, the current plans, and we're saying that the incremental difference in total cost is less. It actually matters quite a bit how the different populations' costs change. So presumably if you're going to preserve Medicaid financing, for example, you're going to have to track expenditures for that population. And if expenditures increase, then your federal match increases. So that savings amount, you really need to decompose it into current revenue and then future revenue sources before you can make an assessment about what's actual savings. It could be all federal dollars that the state has limited flexibility to do anything with it. So just the point I want to make there is the revenue side matters a ton, especially when you're thinking about what you do with savings. And then the last question is about taking an incremental approach for implementation. I think a lot of people on the work group will have some feedback on this, but I would just note that one of the things we're learning as we go through the modeling exercise is that every population has significant different implementation challenges associated with it. Medicaid, again, is a good example where you have literally billions of dollars tied up in federal funds, and to preserve them, you're going to figure out, you'll have to find an authority solution, be an 1115 waiver or a block grant, some federal authority mechanism. And it's going to be different for each program, right? But when you pull in the populations, you have to do this thing with provider reimbursement where you rebalance to some neutral aggregate level. That's going to get really tricky if you're doing it in a phased approach. And that's just one example off the top of my head. So I'm sure everyone has a lot of feedback on what an incremental approach might look like, but just keep in mind that some of the operational considerations for that might get way more complicated if you do it in parts rather than wholesale. So there's definitely some pros and cons to be weighed.
Okay. Next up is Kelly, followed by Vicky.
I wanted to know, I feel like this was just a fire hose of information for me, which it's fair to say. And I'm hoping we're not drawing big conclusions from this presentation today. I'm hoping we're allowed to, marinate in it and talk amongst ourselves and try to figure it out. Is that the plan?
I'll jump in on this one, Kelly. I think you might have read Liz's and my minds. We were just frantically chatting back because we came to the same conclusion that based on the questions we're hearing and the amount of information that we're all taking in, we're thinking that it makes sense to use today to ask clarifying questions and also offer you an opportunity to do like what we've done with the pre-records in the past, where you can, as you say, marinate in the information, review the slide deck again, and submit additional questions. And then we'll allocate some time at our October 7th meeting to do the processing and deliberation as a group, so that you can take it all in. Yeah. Okay, does that take a little weight off your shoulders there? Okay.
Yes, I was like,
good.
So
okay,
Jamie,
so
Jamie,
today you can, yeah?
Sorry, it's Betsy. I just want to make sure that Shane and Jared are getting what they need out of this discussion. I know they had some, for them to continue their modeling, they may need some input. Just want them to weigh in on that.
I will count on them to jump in and ask those questions if they need that information.
Well, this is Jared. So I think, part of the discussion that we were intending to have today was going to ask some of those questions. Given some of this information, albeit it did come out felt like a fire hose for me. So of information, and it was a lot to take in. But there are some key questions throughout the slide deck that I do think are worthy of getting your input, and I do agree you should have some time to think through this and provide us some feedback on it, because if there are things that we do need to change within the modeling, we certainly want to do that. We need to collect your feedback to do so. So as Aaron mentioned, he wants to talk about Medicare a little bit more. So that might be one of those elements. So I think that was the intent of the breakout sessions. And so I don't think anybody is making you hold or is holding you accountable to making decisions today, and then we scurry off and change our numbers or any of that. So I do think there's some ample time to get some of that feedback or thought process in. Oh, you're on mute. I'm sorry.
Oh, Kelly, are you talking? You're on mute. You there.
Sorry.
There you go.
Is there, and now I just hopped off of seeing you guys. Okay. Is there a slide summarizing exactly what you were expecting from us from the breakout rooms today? That would be helpful too. I think there might have been, but
some of the questions that Jared and Shane had were interspersed in the slide deck. The main questions we were going to ask you was, have the modeling outcomes shifted your thinking generally? And we're understanding that you need to absorb this. So what we'll do, I think what will make the most sense is to send out the slide deck, summarize the key questions we have for you, and also give you an opportunity to ask us questions. And then I'll talk with Jared and Shane and the rest of the team about timing to make sure that we're not creating any delays for them if we wait till October 7th to get your feedback on those questions. And we'll come back to you if we need to make some adjustments there. But I think suffice it today to say we'll use this time until 2:45, so another 10 minutes. We'll use this time to continue getting clarifying questions out on the table, and then we'll give you some opportunity to do that after this meeting. Okay, Vicki, you've been very patient. Let me unmute you here.
Hi.
There you go. Hi.
So I see on slide 9 that we have removal of cost sharing as a factor that has a short-term increase to the state. And I'm still wanting to know about the data behind that. And I see it says short-term now instead of just increased cost. So I'm just wondering, is there, where are we getting that? I think of people having access to care earlier that is easier, more effective, and less costly, as opposed to somebody who can't pay a copay and then waits till they have to go to the ER and are hospitalized and they have not very good outcomes. So I'm just wondering, is there any data we can get from like Canada? Since they don't, I know in the Indian healthcare delivery system, as I said several times, there's no cost sharing, and I don't see the impact, we don't see people overutilizing in the way that I think is somewhere baked into how people think about cost sharing. So that's question 1, sorry. And my second question is about the all payers claims database. I hope I said that right. Is there any way to use that information to help understand cost as well?
Thanks for those questions. I'll tackle them in order here. On the cost sharing, despite the fact that the slide says short-term cost increase, that particular, what that means in this context is that those are costs that are currently borne by individuals that would now be borne by the plan. Additionally, so there are two types of effects. There are those that change the aggregate picture, increases and decreases, and then there are those that shift the accountability into the model. That large impact of upwards, I think it's nearly $6 billion. Those are costs that are borne by individuals that we're assuming would be brought into the plan. In addition to that, you do have impacts on utilization because you're changing the basic individual economic decisions that individuals are making when you remove cost sharing. And that presumably has a couple of effects. So the first effect is that where there was a barrier to care, there no longer is, and people will access care. And that can be not just, when you remove all cost sharing, that can include higher cost care settings as well that others. So for example, there are reports that show that Medicaid utilization of ER is higher. The reasons for that are many, and that includes potentially not having access to primary care, but not having a financial barrier to walk in and get care when you need it can also result in increased utilization. So it's really quite a complicated dynamic when you think about completely removing cost sharing and then thinking about utilization assumption. But in the model, we do also assume that there are some savings attributed to reduced exacerbation of conditions because they're getting that earlier care. So they're getting the prescription. So we have an increase in utilization of prescriptions, for example. But with that, we have a decrease in utilization of hospitals. That people are getting the care they need because they can afford it, but their conditions aren't getting to the point where they're very sick and then more expensive. So we do have all of those factors baked in. We're just trying to show that the work group made a really critical decision when they decided not to include cost sharing at this point in the model. That pulls in a lot of money that'll have to be paid for through taxation, essentially, or whatever revenue streams we land on. But we do have those savings assumptions as well. The second point on the APCD, the APCD actually is missing massive chunks of utilization data. It goes back to those ERISA plans. So in Washington, there are a lot of self-funded plans, and under federal statute, states cannot mandate that they contribute data to the APCD. I saw that it is optional for them to do so, but it comes at a cost, and I just don't know if they're volunteering to do so. But even with the APCD, there's a lot of data that we just don't have access to because there are just so many funding streams in the healthcare delivery.
And for the benefit of everyone out there who struggles with acronyms, APCD, and correct me if I got this wrong, Shane, is all payer claims database, correct? Okay.
Thank you.
Great. I just want to do a quick time check. We have about 5 minutes left here, and I know there's still lots of questions. So I want to try to get to as many as I can, but I also want to make sure we preserve time for our discussion later. So I'm going to ask folks that have your hands up. If you have a question that you feel like really needs to be surfaced right here in this conversation, please by all means ask it. If you feel like it's something that you could submit and we could post an answer later, you can go ahead and lower your hand. I have Dr. Weinberg, and then actually Jane sent me a chat request to speak, and then I've got Aaron and Dr. Kovar after that. We'll try to get to everyone. Dr. Weinberg?
Hi, mine is more of a comment than a question. And it stems from the fact that these numbers all assume that nothing is going to happen until 2022. That's fine. It takes time to do things, but we need to realize that, first of all, without federal cooperation, we're going nowhere anyway. And federal cooperation may be much more available by 2022 if we get a friendly administration. And if we don't, it's time to move to France anyway. So that's the other big thing I want to say is our job is to do what's right for the people of the state of Washington. It is not going to be easy, and it is going to take a lot of time. So the journey of 1,000 miles begins with a single step. That quote, by the way, goes back thousands of years to China. I looked it up.
And Dr. Weinberg, that's the perfect segue to our conversation after the stretch break, when we'll be talking about implementation, the implications of that. So Jane, followed by Aaron, followed by Dr. Kovar, and then we're going to take our break. Jane? Oh, let me unmute you here.
Okie doke. So it would, Shane and Jared, it would be really, really helpful to have a little bit more information, whether it's now or in your materials that you send out, around the assumptions that were made around provider reimbursement. I think I heard you say that you were assuming it was sort of net neutral, that Medicaid would come up and commercial would come down. But given the very varied distribution we have of how many Medicaid and privately insured and Medicare folks each provider takes care of, it could have a really, really differential impact on providers. So additional information about that would be appreciated.
Yeah, and I think part of it, I think that we did a case study thing where we kind of modeled out, I guess, worst scenario with high exposure commercial, high exposure Medicaid and what the potential ramifications would be. But we hear you loud and clear if we can get that information out to you and share that information with you in terms of what it would look like, we certainly will.
Thanks.
Okay, Aaron's up next, followed by Dr. Kovar, and then we'll take a break. Aaron.
Okay, so first I want to endorse, I think Jamie, you said that, or somebody said you'd come back to us with sort of a decision tree or a set of questions that the group needed to discuss and sort of answer to move the modeling along. So I just want to say that's, I think, the missing piece today, so that would be really helpful. I have one question and one additional comment. The question is on slide 6. The distribution of status quo personal health expenditures. I just don't understand the difference. I mean, I understand that there is a difference between reported and imputed private health insurance. So I don't know, are you assuming is the imputed more accurate? More, is that what you're using in the models? That's the question. Just about this issue around what would happen to utilization if you take away cost sharing. So we have two kinds of somewhat contradictory evidence. So one is sort of internal to the US Health Services research, which I think pretty consistently shows that if people who don't have insurance get insurance, their short-term utilization of some services go up, sort of the pent-up demand thing. And I think that validates your notion that over time, probably that additional utilization is moderated as people get the services that they were delayed getting. But the contradictory stuff is really the comparison between US and other industrialized healthcare systems, where you see without point of service cost sharing, higher utilization in many of these countries, higher hospital stays, more use of physician services than in the US, but lower overall spending. Now, I assume what happens over time is that the cost per service, that is the price paid to providers, moderates over time. But it seems that is something that the model or our discussions or something needs to take into account, not in the first year, but 5 or 10 years down the road. So just a comment there.
Shane, would it be helpful if I put slide 6 on the screen?
I have a quick verbal explanation for that. It's probably okay. That's a good question, Erin. So we actually include both. So what's included in the blue bar, what's included in the reported private health insurance, the commercial plans that are not self-funded, there actually is pretty robust reporting for many of them, or for most of them. And so to the extent where we can capture that actual utilization we have, the bar that's imputed is to complete the spectrum of the total private health insurance. So that's trying to capture all of the not reported expenditures, such as the ERISA plans where the detailed validated is not included. So both are included in the model. It's not that we've adjusted the reported amount. Hopefully that helps.
Okay, last question from Dr. Kovar. Oh, Dr. Kovar, you're still muted. Can you unmute yourself?
Hi. Okay.
There we go.
I'm not intending to ruffle feathers, but rather in the spirit of transparency. Jane, it was interesting when you reminded us about the potential role of managed care organizations, MCOs, but you chose you happened to randomly chose 3, United, Molina, I think AmeriGroup, that are all for-profit organizations that are beholden to stockholders. There is other option that is not, that's nonprofit. And it seems we should grapple a little bit with the idea that if this is going to be administered by private entities, that there is a difference in for-profit and nonprofit status, or at least we should understand the magnitude of that. And so Shana and Jared being able to communicate that to this process so that recommendations can be made might be very helpful.
Just to make sure I'm understanding the point, you would like to get information from us on whether or not-for-profits have a greater margin that would contribute to greater costs?
Or the opposite, that if non-for-profits are less,
yeah, right.
that we would, what is the magnitude of that if they were chosen to administer that, and that either for-profit organizations were not in the able to compete in this scenario, or that profits were regulated, how much potential savings is there if this needs to be a redistributive process rather than additive?
That's a good question. I don't know what data is available, but we can certainly look. I would note anecdotally that we did a fairly comprehensive comparison in that same vein of hospitals between not-for-profit hospitals and for-profit hospitals here in Colorado. And the outcome was actually reversed, where it turned out that the not-for-profits were significantly less efficient. And so while their profit margins are theoretically reinvested, that doesn't necessarily mean they're cheaper. Clearly, there are lots of reasons why you couldn't extrapolate that result directly to managed care plans, but I just want to throw out a grain of caution that I don't know what the data is on that, and it might be a little bit misleading to just look at that profit margin assumption, because there's also efficiency and other considerations as well.
Mm-hmm. Thank you.
You as well. Thank you.
Okay, we went a little bit over 5 minutes, so I hope you don't curse me if I cut our stretch break down to 5 minutes. Since we're getting, we only have an hour left together after you come back. So if everyone can be back here, my clock says 2:51. So if everyone can be back on your screen at 2:56, we'll move into our next discussion, and we'll still have plenty of time to cover that. So everyone take a little break. We'll see you in 5 minutes at 2:56. Okay, I see folks coming back on the screen. Liz, when you're back on, if you could queue up Nora and Janine's presentation. We'll get that rolling as soon as, okay. Okay, welcome back, everyone. Now is the time when we are going to switch gears and discuss administration and feasibility, do a little deeper dive into that. So prior to today's meeting, you reviewed a pre-recorded presentation, and hopefully some of you wrestled with the RAND study, particularly the section we recommended you read about feasibility and implementation. And now Janine is just going to walk you through just a few more pieces of information that are complementary to those to orient us. Then we're going to move into 3 breakout discussion groups to discuss these issues. So Janine, you want to take it away?
Sure, thank you. So I'm Janine Smith from the Health Management Associates. Can people hear okay, Liz and Jamie? Sound good? So you can go to the next slide. So as you remember, we have assessment criteria. These were first developed way back when in the pre-COVID era, and in earlier work group meetings further discussed. And we talked about them from both quantitative and qualitative, and how they related to the structure of 3 models. And they sort of landed in about 6 different areas, which we've sort of lumped into: access, governance, quality and equity, administration, and feasibility. So today, considering the models that you've heard about and the thinking of the actuaries, we want to focus on the administration and feasibility aspects today to help us kind of think through, whether it's something unique unique perhaps to the model, but probably more importantly, what kind of implementation strategies and issues do you want to make sure happen to ensure that some of these things do occur going forward. Next slide. So administration and feasibility, again, to remind you, it's, how will the model that impact how you get things implemented and administered. We've had some of that discussion so far this afternoon, but also how it relates and intertwines with Medicaid, Medicare, although again, the modeling has left Medicare out, how it commercial health plans, employers, providers, health systems, tribal health, etc. And it includes the ability to, how do we deal with some of the implementation challenges and think about how best to advise the legislature that this is important enough to go this direction or that direction, model A, B, or C, and hop over some of these hoops. It may require some phasing and incremental advances towards the full picture that all of you would really like to see. But it's trying to provide some guidance and your best thinking with this very broad group that has a variety of experiences, both from the past work done here in Washington and also the knowledge of other efforts across the nation and in other countries that we've briefly reviewed in past meetings. So next slide. So to remind you, the sort of qualitative criteria that as we have termed it so far, that fall into these are these administrative functions. And this is like who will take care of member services or respond to member complaints, concerns, welcome them into the plan, those things that often are done currently, say, by health plans and certainly in the commercial marketplace and also across the 5 Medicaid plans here for Medicaid. Who's going to be working on and coordinating provider network development and contracting, data management, rate development, how those providers are paid, who's going to manage the claims from the hospitals and the providers, care management, who's going to help and assist to ensure that especially those with chronic illness and complicated situations and transitions of care are well managed, quality assurance in the quality of care, governance and staffing of the administrative functions, be it entirely based at the state or through delegation or in the Model C, and a variety of other functions. Next slide. It also impacts administration and how you direct it and how it's set up. Is what would, will there be a focus on value? Will there be a means of trying to focus and address costs, lowering costs, hopefully by reducing duplication of services if you're under a large unit, a large plan or one plan, be it A or B, you would avoid some of this, but it's important to think about it. How do you make sure that quality and access are maintained to control costs, to ensure that the right care is given at the right time and place? What about the challenges on the other side of providers? So administrative simplification to make it not too challenging for the providers, improve what the challenges we all have heard and know about to date with the current system. And looking across the data, analyzing it, understanding, make sure the information is in the right place where it needs to be for care. And how do people either get enrolled if there's an enrollment process or allow residents to enroll in coverage at any time? Again, different models mean different things. C would be different than A or B in this aspect. So again, how it's administered can be very important to both the costs as well as how it really impacts patients and their families. Next slide. So yes, Oregon's RAND study is a little dated. It's about 3 to 4 years old, but having worked on this project, we saw some very common similarities to some of the thinking that this work group has had, and we thought it might be a useful example as one example of how they address some of these issues around administration and feasibility. Their models that they were looking at were very similar to yours. The single payer model was state administered, similar to your A. What we called in Oregon the healthcare ingenuity plan is very similar to B, where it has competing private plans that actually administer the benefits, but still tax financed. And then the public option, very similar to what you're already implementing here in Washington, but expanding that similarly to what this group has been thinking. And comparing those three models to the status quo was basically the RAND analysis. Next slide. So for those of you who did your homework, there was a section that we directed you to, and these are summarized on these tables. I won't read everything here, but you can see where they really did try to address the implementation and administration of those models. And as they were thinking about the fact that, say, in single payer, they're bringing everything in, and I think in our thinking, and Nora, correct me, I think we were thinking about Medicare coming in as well. So there was a significant hurdle there in terms of federal approvals and working with CMS, the Medicaid and Medicare agency, that would need to be tackled. And with some potential third-party contracting, because realizing that the state could not probably do all of it. And so again, back to that, so ASO, we were talking about administrative services support. Their administration, though, would be centralized, which would give you some greater leverage and in terms of negotiation and working with your provider network and kind of centralizing everything. And then they did in the RAND actually calculate what that savings would be. CMS, just to remind, the acronym I've said so far is the Centers for Medicare and Medicaid Services. The blue line is that healthcare ingenuity plan that was similar to the Model B for you, very similar to your Model B. Similarly, but perhaps not as quite as significant an effort, but in administration, because you would be delegating out to the plans, but still very significant in terms of getting approvals, and both at a state and federal level. And then the public option, similar to your public option, has establishing some similar some functions. It's on a much smaller scale, so it's a more limited population, so not as big of a lift. But there still would be some savings that were calculated in Rand's study. Next slide. And then the impacts and feasibility. Again, the first two models of Oregon's are very similar to your first two. So the single payer and the healthcare ingenuity plan is similar to A and B. There really was, really does shift the burden to higher income persons based on how Oregon was considering that it would be a tax-based income that would be supportive to this. And then access would be based on provider supply, not necessarily on willingness or ability to pay because of the universal approach. And there would be some higher costs as Medicaid is moved into the program, as was suggested with the healthcare ingenuity plan, because currently the rates paid in Medicaid to providers are much less than those paid in commercial plans. And then in the public option, it's again a smaller lift in terms of impacts, a smaller decrease in savings, though, subsequently. And then feasibility across the board is the feeling that the single payer A, similar to your A, would have the challenges around the federal and Medicaid, Medicare. In Oregon, they wanted to include Medicare. 1332 waivers are those related to the insurance exchange or Obamacare, as some refer to it. And then ERISA, as noted in the pre-record, is the employer sponsored insurance, supported insurance. I can't blanket on the name. But again, there's those sort of federal hoops that you learned about in the pre-record that would still be there as well. But however, the public option as an alternative there would not be. So this kind of information was summarized to go back to the legislature for them to think about as they thought about these three options. Next slide. So we were going to break out into discussion groups to discuss this further, thinking about your Model A, Model B, and Model C, and thinking about these implementation issues, administrative issues, and other impacts, and where would there need to be some real thinking about recommendations the work group might want to make to identify and address these complexities that wouldn't necessarily preclude you from going with a particular model. But if you go, say, with Model A, then maybe you do it in an incremental way to help overcome some of these barriers, or you really think it's important that this still would be, thanks, Jamie, it would still be important to say, okay, neither Model A, Model B, or Model C really talk about how providers maybe should be paid, not in a fee-for-service way going forward, but definitely need to be in a value-based payment arrangement with the model, whichever one is promoted further with the legislature. And that doesn't necessarily, integral to Model A, B, or C, but you want to make sure that that's a recommendation you want whoever administers the model is going to make happen. So those are the kind of discussions that we'll break out to, and we'll have more. We'll have a facilitator, and I'll turn it back to Jamie to talk about the next steps.
Sorry about that. Next steps are we're going to move into breakout discussion groups for roughly the next 30 minutes. There's going to be 3 breakout discussions. So several of you will stay in the main room with me, and Nora will stay with us to help address any subject matter expertise we need. Then one of the breakout rooms, Betsy will be facilitating and Janine will be the subject matter expert. And the second breakout room, Liz will be facilitating and Shane will be the subject matter expert. And the purpose of this discussion is to really compare the complexities of implementing these models and hear your initial thoughts as to whether what you've learned from the pre-records and reading the RAND study and listening to Janine today has influenced your thinking about the models and why or why not. So we're going to break into those. We'll come back for the last 10 to 12 minutes to do a quick report out, and then we'll do action items and next steps and call it a day. So everybody sit tight. You're going to be automatically moved, or you'll just stay here. And members of the public, you'll be staying in the main room with me. Okay. And may I ask any work group members that can to please turn on your cameras. Just makes it easier for me to see you and engage with you, and also distinguish between you and our members of the public. Thank you, appreciate it. All right. So let's just get started. Let's just dive in here. So as I mentioned before, you did a lot of absorbing of the implementation, some of the implementation issues that will need to be considered and addressed, not necessarily by this work group, but with subsequent work to implement the system. And so the first question that I wanted to ask you is, what were your big takeaways from the pre-recording, from today's presentation, and from the RAND study? I'd love to hear from everybody. Maybe we can do a round robin, and I'll give you a sec to think about it, and then I think I'll pick on Lisa first. So Lisa, go ahead and start talking when you feel like you have some takeaways to share.
Yeah, I mean, this doesn't particularly surprise me, but as I was watching the video yesterday and reading through the deck, I mean, I felt very overwhelmed about the feasibility, I mean, the realities behind, the realities of getting the universal coverage option done, particularly, and I know there are a lot of challenges with ERISA, but particularly ERISA is such a stumbling block that I'm not gonna lie, I felt a little discouraged reading and listening to the video in terms of, you know, we wanna be doing the right thing, as so many folks have been saying. And then part of me also thinks, and we also need to move the needle to some extent. And so if we are looking at a plan that could take, I mean, I know we have a breakdown of how long an 1115 and a 1332 and all of that could potentially take, but if we're actually looking at 3-4 years, which I think when you think about negotiating with the federal, we've got the bill, you got to pass several sessions, you've got to negotiate with the feds, got to figure out ERISA. I mean, I've been absorbing a lot, and I really appreciated the public comment to remind us and ground us of why we're here. And it feels like such an uphill battle right now. And I realize that that's not a particularly articulate thing, but reading through that and watching the video, that's where my brain went, is how are we actually going to overcome the significant barriers we see, particularly with the feds?
Actually, so I think that was very articulate. I think you very nicely characterized the tension that many of you are wrestling with between wanting to pursue change and seeing the uphill climb. Lynette, how about you? What was your reaction or big takeaway?
Boy, Lisa, I appreciate hearing what you were saying. I too felt a little discouraged reading all the waivers we have to go through and the ERISA we have to go through, but at the same time encouraging to see that, no, we've kind of got it mapped out. That may take us a couple of years. And knowing that ahead of time, I think we need to immediately apply. I don't want to make it discouraging that we won't do it. I mean, can you imagine? I mean, just our group alone will be so discouraged. But the public, the people in the United States are looking for the state of Washington to pull it together. So we will do it. Jane, I really appreciated your questions that you had. They were very clarifying. They're areas that I pretty much knew what you're talking about. At the same time, I went, whoa, oh yeah. So thank you.
Nice. Dennis, how about you? Oh, we need you to unmute there, Dennis.
I enjoyed the exchange. The thing that's interesting, we went through this back in the 90s with ERISA. And one of the things we discovered was one of the biggest barriers were the workers from Boeing and some of the other large self-insured companies, because they had a wonderful health insurance and they negotiated each one of those elements. They had everything covered, including witchcraft. And it was something that we really didn't need to deal with, because our intent was to get everybody covered. And so what we had to do is design a system where we'd be able to implement it with the idea that when we got the waiver, when they wanted to join us, we would be able to bring them in. These are a very healthy bunch of people with wonderful benefits, and we'd welcome them in anytime they wanted. But in the meantime, we could have set up, or did set up, a system that would give coverage to everyone else and just invite them in as we got the authority. In other words, it's not necessarily a barrier. It's something that we welcome them in, and we want to make sure they are not afraid to join us, because they can become a terrible barrier.
So it sounds like you came up with a good workaround, or a good strategy or solution back then. Yeah.
Talk to Jane about that. Yeah.
Representative Macri, how about you?
I really appreciate all of the comments here right now. I'll say I started off where Lisa was, where, I feel like I've been here before. You can see that if we can get to this point of a universal system, it has multiple benefits, including cost efficiency, broadly speaking. But the challenge is always, how do we get from here to there? And we've not been able to figure that out. As Dennis is talking, though, I do wonder about, are there newer models for us to try to mitigate against this risk? The risk, that I see, so government is not very well positioned to be the one that takes on the huge financial risk on the front end in order to reap huge financial benefit on the back end. It's just usually the private sector will kind of do that kind of venture capital investment in systems change. But that is difficult to do in the public sector. So I'm just wondering if we could look at some social investment models, because I think what Dennis says is exactly right. The state has to take the risk on the high needs populations, and then the populations that will mitigate the risk and the cost to the state will come later. Politically, they're just not gonna come at the beginning. You're not gonna get the folks with high quality union healthcare plans or in these other ERISA plans to agree to it at the beginning. So anyway, that's just a question I have, because I just spent this whole 2 hours thinking, how are we going to get there? How are we going to get there? And I haven't yet figured it out. But, Lynette, I appreciate your optimism that, we just have to go for it. I just worry, particularly this time, the legislature isn't going to be very inclined towards taking big financial risks. So that's my big concern.
So Representative Macri, I'm hearing you maybe making an ask or a request to see if there's any examples of ways that this could be accomplished where it would involve some risk on the front end with an expectation of some payoff on the back end. And yes, Lynette, I think your pep talk was well timed for the group. Jason, how about you? What are your thoughts, takeaways?
I'm excited to see the information provided by our actuaries and the cost savings and then potential costs associated with bringing in new services to groups who haven't had those types of services before. It's an exciting venture to be able to cover populations who are who it's a universal right to have healthcare, but it's also very interesting to see the costs associated with them. So excited about the potential, but I'm with the group. It's a heavy load to tow in this type of revenue environment.
Okay, so nice to see some hard numbers. You're sharing some of the concern about the implementation. Let's see, how about Jane?
Okay, so Aaron and Denny will remember this like deja vu all over again. But here are just a few thoughts. First of all, ERISA is a major impediment. The only way that I'm aware of that states can try to get at it is through the state's traditional taxing authority. And there's actually a good decision out of the Ninth Circuit in San Francisco about San Francisco's program that basically said an employer would just have to pay a certain amount of money toward healthcare. And they could either do it via contributions to their health insurance for their employees or paying into a fund or however. And the court upheld that because it said we are not telling a self-funded group health plan what they have to do. They make their decision. So I think there are some creative ways to think about that. That's an old decision. It's the 90s, but it's still good case law. The other thing to think about in terms of voluntariness, I might have mentioned this before. Remember, our state passed the Balanced Billing Protection Act in 2019. We keep waiting for Congress to do something, and in the meantime, over 225 self-funded group health plans have opted into the state law. So they are consciously subjecting themselves to state regulation because they get the benefit of being able to protect their enrollees from being balance billed. So maybe there's something that we can learn from that. And then, I mean, the other way that I think about so much of this is, yes, it would be daunting, but we've achieved a lot in Washington State through strategically incremental steps. It's why we only have 2% of kids in the state who are uninsured. And it took us about 5 years to get there. So yes, it's daunting, but the question is, are there incremental strategies that get you closer to where you want to go? Because I agree with Representative Macri. I think everybody at this point is risk averse. So that's it.
Thank you, Jane. Nora, did you want to build on anything that Jane said? I know you mentioned the Ninth Circuit Court. You mentioned some of that in the San Francisco decision in your presentation.
Yeah, I first want to say I had no intent to bum people out by by laying out the steps, and I think that the various people have said this, that the point is really to understand what the hurdles are and not to see them and say, oh, well, we can't do the work. And I know Jane has really similar battle scars and experiences with, and as many of you do, going through the process at the state level multiple times with commissions and work groups, and recognizing that there is this kind of iterative push, and that that kind of, as you said, strategic incrementalism is actually really beneficial, even as you keep your eye on the ultimate goal. So I think it's really important just to recognize that what we laid out in the pre-work in terms of recognizing the barriers of ERISA and Medicare and various other pieces, that those should not be seen as a sign that you can't go forward, but that everyone should be realistic about the work that needs to go into it, and not have the idea that that universal coverage will be achieved in 2021 and all problems will be solved and everyone is all set. Just knowing it's a long path.
Don, can I pick on you now? What were your big takeaways from the presentations and the RAND document?
Are you talking to me?
I am. Yeah, I want to hear your thoughts about your takeaway, about the takeaways.
The more I hear, the less I know. And the kind of people I deal with in my business are employers anywhere from 200 employees down to 1 or 2 employees. And there are some people that I deal with that have 80 to 100 employees that still don't have a health insurance for their employees. And the cost is humongous compared to the profit that they're making. We're talking like more than $1 million just to pay the premiums for those 100, 200 employees. And I think the point of doing it incrementally makes a lot of sense, but I really think we're really kind of in a crisis right now, and that's a perfect opportunity just to bite the bullet and make the steps to solve the problem. But to me, incrementally makes way more sense than trying to convince the whole world to go to a brand new system. When I heard all the actuarial stuff, being in the insurance industry myself, I have to say it's so sketchy that I really can't make any comments on whether or not those actuarial figures are anywhere close to accurate. But I know from being involved with the medical clinic that there's a big number of claims that have never been paid, but the service has been provided. And I don't know how big that is increment. I just don't know how big that is, the exposure there. But all of those are going to be picked up under the universal system and should be. And secondly, is being involved with the medical clinic. The co-insurance payments, you have 2 options. One, you can collect the co-insurance out front and give the service, or say, okay, I will go ahead and give you the service. We'll settle the co-insurance issues later. And they never get collected, or if they are collected, they aren't, it isn't profitable to go out and try to collect it. You don't make as much money trying to collect all those things. But I really, what the Representative Dello, or ex-Representative Dello, or whatever his title is now, makes a real point about the union people I know in Yakima. The union people really resist the whole idea of universal care because they think they're going to have less coverage when it's all over with. They really bargain for some really good benefits. So it just makes all the sense in the world to just add to it incrementally and I think even take some pretty bold steps. And I really would like to see a lot of legislators that don't mind losing, being bold and not go ahead and lose the next election. Just throw it to the wind and get it over with and get it done. If that is enlightening for anybody, I would like to hear.
There was a lot of stuff in there. But I heard you say that you see this crisis as an opportunity to shoot the moon, but you also understand, based on your experience with seeing employers and what you heard from some of our other members sitting here today, that an incremental approach and perhaps if you build it, they will come is a good strategy.
I've talked to several employers that do pay for their insurance, or employees' insurance, and they're looking for a savings. I mean, they really are discouraged with the present system. I talked to employers that have never bought any insurance for their employees, and they're scared to death they're going to be taking on a huge expense that far exceeds their net profit. So those are all of the things that you're fighting up against in the community that I'm involved with. And that's what we're up against. But
well, thanks for bringing that perspective.
Yeah.
Aaron, how about you? What were your takeaways?
Well, forgive me first for lapsing into academia, but what I always told my students about public policy is preparation and patience. So for those of you who are, pessimistic, with all these hoops that have to be jumped through and stuff is, I mean, there's a lot of steps, but you don't make any progress until you try. And the lower you set your sights, the less you'll accomplish. I think that's for sure true. And the preparation side is that, maybe 2021, the 2021 session is not going to be the right session. I don't know that, because I do think that crisis creates opportunities that don't exist in better times. But I think our job is to be prepared. Prepared if it's 2021, great. If not, 2022. So that's, I think, the genius of asking for a path to universal coverage is, we start on that path when the political opportunity arises. There are, specific things around, for example, ERISA. I think if the work group ended up taking the stance of let's build a good system, and as Denny suggested, by the way, Denny, I think you should put emeritus behind your name. You should just do that. I did. If we take the stance of let's propose a really good system that's going to have the outcomes that we seem to all agree with, and if labor, which by the way, I think Denny, I think they've changed some of them have changed their tune since 1993, but if labor or some of the self-funded companies, are reticent at the beginning, fine, let them pay taxes and whatever they're paying for their health insurance until they figure out that, that's just not a good deal for them, or their members or their employees. I mean, if we take that stance, I think that's fine, and it may take a few years to get to 100%, but that would be a worthwhile thing. And just on the actuarial stuff, I think it's a real good start. I really appreciate the work, Jared, that you all did. Clearly, there's more decision making that the work group has to do in order to refine those numbers. But I do think we're on the right track. I would, Jamie, just a suggestion to you and the team is, even though I appreciate the fact that we've added another meeting, I'm still concerned that we don't have enough time. And I'm just wondering if there is some work that we can do between a couple of these meetings that will accelerate the discussions and decision making come October and November. So just thinking strategically, you've clearly shown yourselves to be flexible and fleet of foot, even in the midst of a meeting, to switch gears appropriately so. But I think if we could all put our heads, have our heads in the game between these meetings to advance the deliberations, I think, make it more likely that we get to go by December.
Thanks for that suggestion, Aaron. I'm making a note of that. Bring that back to team. Dr. Tritko, how about you? What are your big takeaways?
Well,
I think that what we have to realize is that if we're going to try to change the funding mechanisms of healthcare, it's not going to be very feasible. It's going to take a long time. We should be focusing on what is feasible on the short term, and that is affecting the delivery of care. I feel very strongly that, you know, we have to include health plans to administer the program. They don't need to bear risk, but they need to administer like Regents does for the state or Noridian does for Medicare. The state must become a more active purchaser of healthcare. They can do that in two ways. One is by regulating providers. The second is by forming a large ACO. It could be based on Medicaid or even better on the state employee health plan. You get a large ACO, you make it available in the exchange, you prove that it can be efficient. A couple years down the road, then getting these waivers becomes a very real possibility. And that would be a stepwise approach, starting on 3, going to 2, and then going to 1, 10, 15 years down the road. That's exactly what the California Berkeley study showed, is that feasibility is what we do on the short term, and we can have these long-term goals, fine, but you have to start taking the initial steps that you can take first. And again, that means that the state has to become a more active purchaser of healthcare.
Okay, and I'm going to just ask Nora to unmute and say quickly for our acronym challenged people like me, ACO.
An ACO is an accountable care organization, and it's an entity that that gets together to take on risk for patients. And generally, I assume Dr. Turco would encourage them to engage in value-based practices in order to manage care and coordinate care in ways that allow them to provide needed services within the amount of money.
Okay. Erin, I'm going to come back to you in just a second, but I see Dr. Dietering's with us, although I can't see her face. It's just black there. But Dr. Dietering, can you share your takeaways with us?
Yeah, I'm not sure why my camera isn't working here. Sorry about that.
That happened to me. That happened to me once too, so I understand.
The lights on, everything looks good. It feels hard to add to the conversation anything that really hasn't been said so far. I feel like I think about delivering a baby, and one of the things that's really important when you deliver a baby is making sure the momentum continues. And I think maybe this is a different way of saying something that that Erin Katz said, which is, there is some momentum in the world of changing how the government deals with the right people have to healthcare, with the cascade care. That is actually a big deal and a big change that has happened. And in my mind, hurrying in some ways to the very end of the process and being anxious for that to happen so quickly and not could very well arrest the labor, so to speak. So the idea of keeping the momentum going of the changes that have been able to be accomplished in the last 5 years by adding to them and continuing on to them with the idea of where we want to get in 15 to 20 years makes a lot more sense to me. And I know that kind of feasibility it's not as sexy, and it's not as it's not as optimal, or in some ways doesn't feel as good as having this thing that we all want to get to quickly. But I guess I'm just really practical. Like, I think we need to just keep on with the momentum that's happened with that long-term goal of where we want to be. But I would rather see us continuing to make those changes that allow more and more people to have access to health coverage than to work so hard toward an outcome that I really do fear that it's just going to be a quick dead end, rather than if we kind of have, we need to get to this universal system, and that is our only, that's the way we want to go.
I would rather keep the momentum of already what's happening, because I think people do have an appetite and they're getting more and more comfortable with the changes that are working out and are making a difference for people.
So Dr. Dieter, I hear you saying, let's, rather than rushing to solve the immediate problems, let's focus on our long-term goal of universal health care, how to the extent that it takes time so we can keep our momentum. Thank you for that. And Aaron, I see your hand up, and then hopefully in our last 2 or 3 minutes together, I have another question for all of you. Aaron?
Yeah, boy, there's so much, Barbara, in that analogy of delivering a baby. You know, but I would say that I've never delivered a baby, but I'm assuming those who have know what the outcome they want.
Right.
Right? They know what
Yep.
the outcome they want. And you're not trying to necessarily rush yourself, but my guess is another part of that analogy is none of us know at the beginning how fast things are going to go. And I think that's definitely true in public policy. We don't know. None of us are smart enough, not even representative emeritus know with any certainty. And so I think what's incumbent upon us is to figure out what we want to build and be ready when the opportunity arises. I mean, it may be that starting next year, depending on what happens in November, that there is we actually see an ERISA waiver mechanism created, which doesn't exist right now, right? Maybe we'll see that. We don't know. So, but if we're not ready, we're not going to be ready to take advantage of those opportunities. So we need to move towards, you know, we need to finish our jobs in this work group. The other thing I want to say is you know, Rod, I have to say that sometimes you and I are on mind meld, and sometimes, you know, it's like the warriors clashing. And I just have to say, I totally disagree with you about whether we have to first fix the financing or focus on the delivery system. I don't think we can fix the delivery system if we don't fix the financing. So to me, that's the exciting thing about this process, is focused on where the money comes from and where it goes. And while I certainly agree with you that there are different ways, for example, for the state to play a more active role in purchasing to make the system more efficient, I don't think it can reach its potential if we don't defragment the healthcare financing system.
Aaron, I think you said that in our first meeting a year ago. So
probably I'm a one song, you know, whatever. No,
I appreciate it. Really quick, I think we have about a minute before everybody comes back to us. I'm curious, and I won't hold you to this, but has what you've taken in about implementation and what's ahead changed your feelings about which model you feel should be the one we recommend? I'm seeing Aaron shake his head. Anyone else have any thoughts there? The reason I ask this is I've heard a lot of support and interest, in particular for Model A, for the single payer model. And what I saw in the presentations with that one also has a lot of the implementation, you know, the highest amount of implementation steps and complications. And I'm seeing, based on what I'm seeing here, it doesn't look like either folks are still weighing it all, or it doesn't look like it's changed your minds about wanting to pursue that for some of you. Nope. See some shaking heads, and I see some puzzled faces. Oh, Jane. Nope, you're on mute.
I know. Okay. I mean, so I don't even know whether the insurance commissioner has a vote on this work group. I have to go back and look at the original proviso.
We don't actually do voting anyway, so you're okay. We just want to.
Okay, good.
We just want to know what you think.
I think what you've heard is there's a shared goal right? But what we acknowledge is that you get places in steps. And so the really interesting question, I think, this is Jane talking, this is not the commissioner. I think the really interesting question for you and Sue and the work group is, strategically, what is put forward to the legislature? Is it, yep, we want Model A, end of discussion? Or is it, yep, we want Model A and here's what we need here's what we think you need to think about to get there? And it's two different approaches, but having worked as a ledge staffer for 20 years, it's probably, I don't know, and I'd like to hear from Representative Dello and Representative Macri. It's really hard to just put a fait accompli in front of the legislature and ask them to just figure it out. That's my frank assessment.
Okay. Lynette, I see your hand up. I think our folks are coming back into the room though. So I'll just remember you have your hand up and maybe we can catch you after we do the report out. Sorry, I think that we were getting to the most exciting part of the discussion there too. Welcome back, everyone. So we have about a little less than 10 minutes to kind of get a quick report out from our three rooms. I want to hear what came up. I'm going to pick on Nora first from my room, who's just going to give us a quick summary of the highlights of our discussion. And then after that, we'll have Janine share what she heard in breakout room 1, and then we'll have Shane share what he heard in breakout room 2. And I'll ask Janine and Shane for you to build on what Nora says rather than repeating if you can. Nora, why don't you go ahead and just give us some quick highlights from our discussion?
Sure. We started out with feeling a little discouraged by sort of recognition of a lot of the work that's quite complex and involved, but that after a few minutes, that feeling kind of moved into a sense that it is more realistic understanding of the work, and that there were a number of people who reinforced the idea that there should be continued movement, recognizing that it's not something that can happen with the snap of the fingers. That there is going to be need for concerted effort, and that is okay, and that working with the overall goal and the overall set of desired outcomes in mind, that work can be done, even if it's stepwise work. So we had some disagreement about whether it's better to focus on financing first, system financing, or on the way that that the delivery system works, but recognizing that those are both areas of concern and areas where more state involvement and more state control can help move things forward. So when asked if anyone had a change of heart after looking at the pre-record and understanding the level of effort involved in getting things passed over a number of years, whether that changes anyone's view about what model they would recommend, and that didn't change anyone's mind about a general interest in A and B as the universal coverage models.
And the only thing, that was great, Nora, thank you. The only thing I would add to that is I think Jane made a really good summary at the end of what we all might think about, which is what and how we report strategically to the legislature. So if we're all sharing the same goal of universal health care in model A or B, but we're recognizing there's a number of steps and there's some issues we need to address in the nearer term, what are some incremental things that our legislators should think about and consider as they move this needle forward? Okay, I'm going to jump ahead to Janine to report out for breakout room 1. Janine, what would you add? What would you add to what Nora said? What was different in your room?
Well, I think there was some concerns right out of the gate on, going incrementally might be more expensive. So trying to better understand the numbers and the information that was already presented today. And then also being able to understand how to translate that, because as things go to the legislature and move forward, explaining things to taxpayers, where the savings accrue to and to whom, and how if it's a big investment up front, do you recoup it later? Those are all very critical things for this for folks to think about. There was the other things that were raised is that importance of access and making sure that it is administered and implemented in such a way that independent providers and rural especially can be participatory, and that they're, whatever needs to be done as you think about the administration, that's how that is important. And the federal challenges, much we asked a similar question, none of these challenges that were presented seemed to phase their choice of which model they would want to do. And a lot of discussion about the state-based Universal Health Care Act as a potential roadmap to maybe get around some of those and maximizing the use of 1332, et cetera. And then thinking also about that a transition plan and the impact of a transition plan is really important, and how can we, job loss and others, rural versus urban, how can that, there's an opportunity to be creative, but really need to think about that. I think the challenges still remain, though, of thinking between a Model A and Model B, and thinking through the differences and advantages of one versus the other. Still needs to be some further thinking about that.
Great, thank you, Janine. And actually that triggered one more thought that came up in my group that I wanted to add, which is this idea that in the presentations you talked about a 5-year timeline to address some of these implementation issues, and that was obviously an estimate. But what we discussed in our group, or what we heard, is that no one really knows how exactly long it'll take, and what's important is to be prepared for that. And that's some of the thinking that this group can do and then recommend in the report. Shane, what about you? What was in breakout room 2 that you would build on from what you've heard so far?
I have 3 key points. The stakeholder engagement obviously came up in our group as well. But I think there were some really salient points that would be great for the broader group. First, that one, there isn't necessarily even consensus within the work group in terms of what the ideal end state is at this point. And certainly externally, that's going to be true as well. That different groups are going to want different outcomes, and some may be wanting to have full universal coverage for everyone, and others may not. They may want to just make sure that everyone has everyone has access to coverage that's affordable, and those look different. And 2 is that we really do need to make sure that we're framing the information in terms of trade-offs. So these are the costs and what the state would have to do in terms of politics, money, and everything to get it done, versus what you get out of it, so that we can have informed policy. And also importantly, so that it can be kind of a foundation for us building trust, which was an important point raised in the group, is that we need to build trust with stakeholders externally as well, and internally with the work group as well. There was broad acknowledgement for the federal challenges, and that kind of teed off kind of this concept that it's worth evaluating incremental approaches. And then also there was a point made that there is actually some really good infrastructure already in place in Washington that can help facilitate making some of these core functions that would be required under universal health care more realistic. So scaling up the third-party biller from HEB and SEB as an example. Additionally, that there's been legislation contemplated that kind of sets a framework for transition activities as well. So stakeholder engagement and thinking about that framework a little more robustly, thinking about incrementalism due to some of the implementation challenges, and acknowledging that we do have good infrastructure in place for a lot of the activities that would need to happen.
Very nice, concise summary. Thank you, Shane. I did promise Lynette, because she put her hand up right before we broke. I wanted to make sure if we had a moment that I could give her time to say what she was going to say. So Lynette, we're short on time, but I do want to hear what you have to say. So let me just unmute you here.
Oh, good. There we go. Yeah, well, we also talked about who was going to be resistant, and we talked about labor people, unions. No, they're not anymore. We've grown out of it. Part of the Washington State Nursing Association, we're a union. And with Washington State Labor Union, they have all agreed that we need to have this universal health care. They will be working with us. I liked what Dawn in our room said, we're in a crisis. Well, I think this is our momentum. I don't think we should let this crisis waste away. We need people to understand that there are a lot of people that have lost their insurance, and it's really been quite sad, and lost their lives because of it. I think this is the time to push. And the last thing is we had Representative Macri in our room, and I think she, along with several other legislators, we need to give them a toolkit. We'll need to tell them what it is that we're going to do, when we're looking to do it, give them step by step, and we will be there lobbying. So that's it.
Thank you, Lynette. You get the last word today because I'm going to now move into summarizing our action items and next steps, because believe it or not, time flies when you're having fun. It is almost 4 o'clock. So first of all, thank you everyone, both for your contributions today and your patience with us kind of being flexible and moving around our approach today. But I think it worked out well, and I appreciate everybody's flexibility. Couple of action items and next steps. First of all, as promised, we're going to make sure you get the slide decks from today. Those for members of the public, those will also be posted on the HCA website, and we'll notify you when those are up. Work group members, you'll have an opportunity, I'm going to use Kelly's words again, to marinate in the information and submit additional questions, and we'll post answers for you. So you can really, I mean, our goal here was to get you comfortable with these data so you can start really using them. And so that's what we'll do between now and our October 7th meeting. We're going to look at our agenda for October 7th and see how we can work in some time to then start deliberating on this stuff. But in the meantime, the project team will consult so that we can make sure that whatever we're doing, we're not putting Jared and Shane in the position of not being able to continue with their work because they don't have information. So we'll be getting back to you on that. I did hear a request from someone in my room that I wanted to share with all of you. I can't make any promises on this. I'm just saying we'll discuss it, which is to think about what the work group can possibly do between meetings to accelerate deliberation so that we can still make it to the finish line on time. So I will bring that back to the project team for discussion. And then there was another request in my room to look out for if there are any models for systems change around like how you do this when it really requires a big upfront investment for realizing longer term financial benefit. So that's something else. I don't know the answer to that, but we'll see if we have an answer to whether those models exist. Then we got 1 minute. What's okay. Your, sorry, can you unmute yourself?
Can you hear me now?
There you go.
Okay,
yeah.
Cool. No, my only thing was I just wanted to add that I had a request, and Kelly did, of the facilitators hopefully offering some existing like administrative ideas, right? So if we're talking about administration and feasibility, there's a huge list, you know, in our breakout rooms of things that need to be considered in terms of administration. We could probably spend a work group session on like 5 of those. So are there existing administrative models that we can look at, like in countries or other systems that are similar to what we're proposing that we can look at?
Okay. Any models we don't have to reinvent?
Yes.
Okay, I'm going to take Ronnie, and then no one else raise your hand because we are out of time. Ronnie.
And I just wanted to say that we have identified a lot of costs of implementation, and I think those are very real, but we're not in this alone. Bevan just mentioned other countries, but there are other states that we've been talking with about these issues, and there is a precedent for our state to share with other states and share processes, that this is not an insurmountable problem. we're not in this alone.
That's a very good note to end on, actually. Thank you for that, Ronnie. One last action item for all of you is you should be expecting to see that revised draft outline for the report early next week for your review and feedback. Pretend I said that before Ronnie said his point about not being alone, so that we can leave you with that message as opposed to my boring housekeeping. Everyone, as ever, it was a joy to see you. You were the bright spot in a smoky week for me. Thank you for the great conversations today. I look forward to seeing you next month in October. And everyone stay healthy, stay well. Hopefully we'll get some rain soon. Take care, everyone.